तो कोना करना था ना। हाँ हाँ हाँ, ठीक है।
We are live.
Okay. Good evening, all. It's a pleasure and honor for Jharkhand Ophthalmological Society to welcome all the respected guest faculties and the local JHOS members across India of national and international fame in part two of the midterm conference, virtual conference of Jharkhand Ophthalmological Society. We have selected an array of top 16 speakers across India who have won international award for their presentations in their subspecialty. Many have won in retina, some in cornea, some in OP, and some in glaucoma. In part one, we had kept innovation sessions, which was very much appreciated. And apart from case presentations to involve PGs and young doctors and guest lectures also. This time, we hope that the international hero session will keep you engaged and stimulated, as well as JHOS potpourri session, which is kept to involve local faculties. JHOS is a small society, but its impact has been felt nationally. For the second time, the society has been recognized at annual conference in Kolkata for being the best society in the category of 100 and 500 members. And this was given for the best CME activities and PG teaching projects and public awareness campaigns, which we conduct throughout the years. I'm repeating this time because, but this time the faculties are, this time the faculties are new. So I'm repeating that we have won it for the second time. And in 2019, for our best contribution in AIOS, ARC, Jo Se Jo Jalao, diabetic retinopathy campaign, for the maximum contribution, our society was honored by President AIOS in the annual conference of AIOS. So now I welcome you all in this online midterm conference of Jharkhand Ophthalmological Society, which is a small society, but its impact is felt nationally. And with this, over to President Jharkhand Ophthalmological Society to for inauguration of this second part of the midterm online conference. Over to Madam Nandita Agrawal.
Thank you, Bharti. Good evening to the and welcome to the galaxy of distinguished and eminent members, coordinators, chairpersons, and to the second part of this 22nd midterm conference of JHOS. I also welcome all speakers and award winners for their original research and presentation at the international level and making India proud of them. This International Heroes session has been added for the first time in JHOS. A word of acknowledgement for Dr. Bharti Kashyap, who has strived unceasingly and continuously to get all awardees in all subspecialties of ophthalmology on one platform. I know it is a Herculean and time-consuming job to bring together so many award winners on one platform at the same time for the benefit of our members. All ophthalmologists attending this conference, I'm sure, will learn something from this session. I now declare this second part of the 22nd JHOS midterm conference of JHOS open.
Thank you, Madam. Thank you, President.
Over
Madam.
to you, Bharti.
Thank you, Madam. So we are starting the first session. In the first session, our session coordinator is Dr. B.P. Kashyap. He is the past president of Jharkhand Ophthalmological Society and the management committee member. Dr. Sunil Kumar, he is the HOD head of the department of the prestigious, largest medical college of Jharkhand, Dr. Deepak Lakra. He is also there. He is the senior faculty of the Rio RIMS. Dr. Rahul Prasad, he is the senior retina faculty of Rio RIMS, Jharkhand. We have chairpersons with us. I can see Dr. B.N. Gupta, sir. He's the past president of JHOS and the past president of ISOC. Dr. Rajiv Gupta, he's the past president of JHOS. Dr. Vinay Gupta, he is the very eminent cataract and glaucoma surgeon from Giridih. And Dr. Ajay Gupta, he is the secretary of Jamshedpur Ophthalmological Society. We have our office bearers, our honorary secretary, Dr. S.K. Mitra. He is there. He is the eminent cataract and glaucoma surgeon from Jamshedpur. Our honorary treasurer is here, Dr. Vibhuti Bhushan. He is one of the best practitioners of Jharkhand, cataract and retina, and he happens to be my batchmate also from MBBS days. And we have the very prestigious discussants also with us, about whom there will be a detailed introduction by our session coordinators. So there are Dr. Ranjit Maniar sir, Dr. Ruchi Goyal, Dr. Vishal Agrawal, Dr. Vibhuti Kashyap, Dr. Devesh Kumawat, Dr. Pranita Sahai, and Dr. Anindya Anuradha. These are the people who will be playing the role of discussant. So for the detailed introduction and the coordination of the first session, that is the International Hero session, I am over to the discussants. The group of discussants, Dr. Kashyap, Dr. Sunil, Dr. Deepak, and Dr. Rahul Prasad. Over to you. Conference hall.
Thank you, ma'am. Thank you, ma'am. We are audible?
Yes, yes.
Okay, ma'am. So very good evening, and hope we have a very tremendous educative session today. To start with, Dr. Kashyap sir is going to introduce Dr. Srinivas Joshi first.
Dr. Srinivas, popularly known as Dr. Srini, he has completed his fellowship in VR from University of Toronto, that is North America, and a fellow American Society Retina Specialist, that is FASRS, executive MBA from IIM Kolkata, working as director and research and VR consultant at Joshi Eye Institute for past 14 years, has bagged many prestigious awards like Red Beckler Award by American Retina Society for 7 consecutive times. It's no jokes. AIS Honor Award by All India Ophthalmic Society 2024, and International Hero Award by AIS 2017 to 2024. He is one of the first few Indians to get trained by Argus 2 retinal implant, first US FDA approved artificial retina, presently serving as member AIS ARS South Zone, and he has a special interest in macular surgeries and pediatric retinal surgeries. So and the next speaker is Dr. Vishal Agrawal. He has done his MD from AIMS, FRCS Glasgow, FASRS, FSCS, etc., and many more are there. He is presently as the chairman, scientific committee of Rajasthan Ophthalmological Society. He is the past secretary of Jaipur Ophthalmological Society, ex-professor, Department of Ophthalmology, SMS Medical College, Jaipur. His area of interest is surgical retina, ROP, and macular interface disorders. He has presented numerous instruction courses, co-authored books, published in index journals, and performed live surgeries in national and international conferences. He is on the editorial board of many, many journals like Indian Journal of Ophthalmology. He is the principal investigator of more than 6 phase 3 FDA approved multicentric trials on AMD, RVO, and uveitis. He has got several awards to his credit, like runner-up Image of Year ASRS Stockholm 2024, American Society of Retina Specialists in Seattle 2023, Red Beckler Best Video Award in 2020, Image of the Year American Society of Retina Specialists Chicago 2019, Best Video Prize in Retina, that in Copenhagen 2016, CS Reshmi Award, Best Video Award in AIOS 2017, AIOS Ophthalmic Hero Award 2017, Suraj Narayan Gold Medal in ROS 2016. Best Video Award in 18, 19, 20, 21 in a row. And Best Video Award in JHOS, that is in 2016, 17, 18, 19. So many awards on his name, including the AIS Ophthalmic Hero of India Award 2021, Best Surgical Video Delhi Retina Meet 2022, IJO Honor Award for Peer Review in 221, and AIS Ophthalmic Hero in India Award 2020. Sequence में कुछ changes आएंगे.
There is some change in sequence because of the Karwa Chauth. So Dr. Kashyap can introduce Dr. Arvind Maurya. And after that, Dr. Rahul or Dr. Sunil can introduce Dr. Ankita and Dr. Aarti Heda, because we are going to take these two ladies' presentation first.
Okay, okay.
Am I clear?
Yes, you are absolutely crystal clear, madam, as usual. So, who can know better than me about Dr. Arvind Kumar Maurya? I love him. He's my very good friend. Whenever we go to the conferences, he's always there with me. He's an additional professor in head, cataract, glaucoma, refractive, squint, pediatric ophthalmology, and medical retina services, AIMS, Hyderabad, India. And he is also first Indian to win Ophthalmic Star Award in Amsterdam ESCRS in 2021. AIS International Hero Award for the year 2021, 22, 23, 24 in a row. So you are great. First to receive AIS Senior Academic Achiever Award 2021. One more prestigious AIS award, that Best Free Paper in Cataract and Refractive category. IIRSI Gold Medal, Best Innovation, Best Cornea Video, and Free Paper Award IFFA DOS, Best Video Awards. And heading many projects based on AI on DR and glaucoma, 600 international and national presentations, more than 100 international and national publications. He is also associated with journals like Editor UK JHOS, Section Editor IJO, Editorial Board Member and EC Ophthalmology, WJCC, IJOVS, DOS, Times, and JHOS, and has been conferred 12 Oration Awards, Best Video Award and IJO Honor, Teacher of Tomorrow, Best Poster Award by AIOS, and his international faculty is Cisco and WOS, ICO, and ESCRS, and his special enterprise, social enterprise of the year 2023 award by Ophthal Practice Development. And he is always renovating something, innovating something, and coming out with new ideas. And very truly, he's given about, like, teacher of teachers, teacher of tomorrow. So you are great. Thank you.
Thank you so very much, sir, for your kind words. Thank you.
So, continuing our introduction for our speakers.
We are showing.
Yes, ma'am.
We are showing slide from here.
Yes, ma'am. We are waiting for you.
Sequence.
Rahul, why don't we introduce one by one just before the talk of the speaker? That will be better, rather than introducing everybody at a time.
Sir.
Just before the talk, you introduce the
sir. Actually, the sequence
that will be better.
वो बहुत ज़्यादा यहाँ से कंट्रोल करना पड़ रहा है.
अच्छा, नहीं, टॉक के पहले करने से ठीक रहता है. Anyway, whatever suits you, no problem. Whatever is convenient, please go ahead.
बताओ ना. इसके बाद आप शुरू करिए. इंट्रो कंप्लीट करो.
Yes, ma'am. Our next speaker that we are going to introduce is Dr. Veer Singh. He has done his higher education from MBBS from JNMC Belgaum. He has done his Vitro-Retina Fellowship from Sohan Singh Eye Institute, Amritsar, and from Shankar Netralaya, Chennai. He has done his UVA observership from Shankar Netralaya, Chennai, and also he has got his phacoemulsification training from Shroff Eye Charity Eye Center, New Delhi, and Shushrut Eye Foundation, Kolkata. Currently, he is affiliated as a retina surgeon at SB Dr. Sohan Eye Singh Hospital, Amritsar. He has cleared up his ICO retina examination in 2018, and he has got a number of awards to his name. That includes runner-up video award at IRSI IFA 2020 Chennai, Best Video Award at Opthicon 2022 Amritsar, winner Young Producer Video at the Film Festival, winner IRSI, first prize winner of VRSI Image Competition May 2023. He is also one of the awardees of Red Buckler Award for the Best Surgical Video Retina Video at ASRCS USA. He has got his Best Video Award at AVPRS 2023 in Hong Kong. He has been involved in a number of conferences which has been organized and hosted along with him. That includes Amritsar Retina Meet in 2019 and VRSI Retina Symposium Amritsar 2019. Now, he has got a number of publications under his name, various national and international publication under his name. The next speaker that I'm going to introduce is Dr. Prasanna Venkatesh Ramesh. Now, he is an MBBS MS gold medalist, DNB, FICO glaucoma, FICO cataract, FICO gold medalist, FICO glaucoma, fellowship in glaucoma surgery, and research from Satyan Eye Care and Coimbatore Glaucoma Foundation. Currently, he is the research director and glaucoma head at Mahatma Eye Hospital Limited, Trichy. He is the DNB FAT examiner, DNB coordinator of the MEHPL Institute and Thesis Guide. He has published about 180 articles in various PubMed index journal with 371 citation and in the high index score of 9. He has delivered 477 scientific presentation at various international and national conferences. He is in the editorial board of General Ophthalmology and Video section of IJO. He is also the associate editor board member for Tamil Nadu Ophthalmic Association Journal of Ophthalmic Sciences and Research. He is currently the joint secretary for Young Ophthalmical Society of India. He is also in the management committee member for the Tamil Nadu Ophthalmic Association. He has conducted various instruction courses as chief instructor in ASRCA, APAO, AIOS, GSI, and TNOA. He has been the recipient of more than 20 awards in ASCRS, 1 in WGC, 5 in APAO, 15 in IRSI, 37 in AIOS, 12 in GSI, 19 in TNOA, 7 in DOS, 12 in YOSI, and 1 in Arvind Eye Care System conferences. He has delivered 1 oration and performed 2 live surgeries. He has area of interest include glaucoma surgery, MIGS, moving images, 4D diagnostics, augmented reality, artificial intelligence, and academic filmmaking. The next speaker that I'm going to introduce is Dr. Saurav Pirshad. Currently, he is working as a clinical and research associate. He also looks after the ocular oncology, orbit, and ophthalmic plastic surgery with Dr. Santosh H. Hanover at the Center for Sight, CFS, Hyderabad. He has completed his long-term clinical fellowship under Dr. Hanover at CFS, Hyderabad, and he has been awarded and accepted as oral and poster theater presentation at APAO and AAO 2023, respectively. Now I hand over the mic to Dr. Sunil, who will be introducing further speakers.
Thank you. Very good evening. So the slides of Dr. Devang, please. Yeah. So it's my pleasure to introduce Dr. Devang Angmo. She is the additional professor of ophthalmology,
Pallavi.
glaucoma, cornea, cataract, and refractive surgery services in the prestigious RP Center, AIIMS, Delhi. She is executive member, Glaucoma Society of India, 2024-26. She is the ex-executive member, DOS. And she has it with his name over 140 research papers, over 35 book chapters, and 4 textbook contribution. He has various awards to his name from national bodies, notably ICMR Young Investigators Travel Grant 2014, AIMS Excellence Research Award 2019, Best Free Paper in DOS 2020, GSI Best Video 2024, and International Society like Asia ARBO Travel Grant Award 2015, World Glaucoma Congress Travel Grant 2015, 19, and 23, APGS 2024 Young Investigator Awards, APAO LDP 2023. She continued to excel in her field, contributing in research and ocular genetics, training and teaching the undergraduates and postgraduate students, and she is serving as faculty in conferences various worldwide. So next, I am going to introduce Dr. Aarti Subhas Heda. She is DNB, FRCS, FACS, FICO, MRCS Edinburgh, Fellowship in Cataract and Refractive Surgery, ICO Glaucoma, FGCPS, FCO, ECSA, PGD, MLS, MNAMS, so many degrees. She is the consultant and assessment surgeon based in Pune, and she has many international achievements like American Academy of Ophthalmology Rotary Fellowship for the 2024, Your Travel Grant winners at 37, Singapore, Malaysia joint meeting, Transforming Paradigms in Ophthalmology, 19 to 21st January 2024, Academia, Singapore. She has got travel grant winner at World Ophthalmology Congress, 9th to 12th September 2024. Winner of 2021 Annual Photo Contest, Cataract and Refractive Surgery Today, December 2021. She also won the Best Surgical Video Award at 36th Asia Pacific Academy of Ophthalmology Congress, 5th to 11th September 2021. She also received the APAO 2021 and Your Travel Grant Singapore 2024. Thank you. So next introduction will be done by Dr. Deepak Lakda, sir.
Slide of Dr. Bharat Gulani, please. It's my pleasure to include Dr. Bharat Gulani. He's done his MBBS from Pune, DNB from Pondicherry, FCRS from Pondicherry, FICO CO from UK, FICO CO from AIMS, FICO in AIMS, FSCS, MRC from UK, and NAMS from the New Delhi. Currently, he's the consultant cataract, cornea, trauma, external disease, ocular surface refractive service at Gomabai Netralaya Research Center, NIMEC, India. He is keen interest in research and publication. He has published more than 350 peer-reviewed articles in the various international and national journals, 343 PubMed index, and he reviewed over 500 papers for the various journals. His keen interest in the microkeratitis, keratoconus, dry eye, ocular trauma, and lamellar surgeries. He has won more than 50 awards at the various national and international conferences, including the Best Paper at Ophthalmic Society at Kenya, Best Video at APAO Bali 2024, JOCRS Young Achiever Award 2024 at Tirupati, Icon AIOS International Heroes Award at 2023-24, Best Paper Award at AIOS 2020-21, 2022-2023 AIOS MTC Patna, Best of IGO Award at 2020 and 2021 and 2022 and 23 IGO Award from maximum citation from original articles, ACOIN International Oration Award at 2023, AIOS YOSI Easy Writing Competition 2023, first award, AIOS International Travel Grant recipient 2023, winner All India Institute AIOS 2023 Mega Quiz, free paper winner DOS 2021, best case presentation in DOS 2021, best paper award DOS 2021, best paper cornea and uvea TNOA 2021, and best video award APAO 2024, and best video award AIS 2024. Next, I am going to introduce Dr. Kirandev Kaur. Dr. Kirandev Kaur has done MBBS from AIMS Punjab, DNB from Pondicherry, APOS Pondicherry, FICO and FICO pediatric glaucoma and established AIMS, FSCS, MRCS, AD at UK, and MNAMS from New Delhi. He is the consultant in cataract, pediatric ophthalmology, strabismus, neurophthalmology at Gomabai Netralaya and Research Center, Nemach, Madhya Pradesh, India. He has keen interest in research and publication, and he has published more than 320 papers at reviewed articles in various international and national journal 2020 PubMed Index, and he has reviewed over the 2050 papers for the various journal. His keen interests are myopia, pediatric accommodative anomalies, strabismus, complex strabismus surgeries, and pediatric cataract management. She has won more than 25 awards at the various national and international conferences, including the best paper at the best video award, APO Bali in 2024, JOCR Young Achiever Award in 2024 at Tirupati Icon, Delhi Ophthalmic Society 2021, AIOS International Heroes Award in 2024 and 2023, and Best Paper Physical Pediatric Award at AIOS 2021, and Best of the IGO Award. She is the youngest recipient of ACO Equine Award at AIOS 2022, and she is also the winner of IVK International Ophthalmology Award in 2023, and she won the Quiz Award in AIOS 2021 and 2024. Next, Dr. Akita Aishwarya. Akita Aishwarya, she is the MS Gold Medalist, FSCO from MRCS ED, and a fellow in the ocular oncology and oculoplasty. Currently, his place of work is PGIC Oneda. Is a reviewer of the American Journal of Ophthalmology in AGO, and at 2024 till present, his review in the Indian Journal of Ophthalmology (IGO), and 2020 till present. She is associate editor in the Open Access Journal of Ophthalmology 2020 till present. He had won the many awards as the AIOS International Hero Award in 2020 and 2024. The Best Paper Award, American Academy of Ophthalmology, AAO, one of the youngest recipient award in 2022. Best Paper Award, Bangladesh Ophthalmic Society and Oculoplasty Society Society of Asia in 2022. And the Best Video Award at the Asia Pacific Vitreoretina Society in 2021. Delhi Ophthalmic Society DOS International Star Award at 2021, and she is felicitated as one woman of the society inspiration of annual WOS conference 2021.
Thank you. So without further delay, now we will start this session. That is the International Hero session. And each speaker will be the 77 minutes followed by 5-minute discussion.
First, we apologize with the discussants because we are going to little bit delay for their introduction, because if we start introducing the discussants, there will be delay in Karwa Chauth time. So, considering the Karwa Chauth Puja time, we will be introducing detailed introduction of the discussants will be taken later. And they are very, very bright discussants. So for the first paper of Dr. Aarti Heda's presentation, the discussant is Dr. Pranita Sahai. Out and out Amazonian and very bright. Welcome, Pranita. Over to Dr. Sunil. Over to Dr. Aarti Heda. Please share your screen.
Yes,
Okay.
yes.
So I invite Dr. Aarti Heda for his presentations. The keratoprosthesis, the last ray of hope in a bilaterally blind patient with Steven Johnson syndrome. So over to Dr. Aarti Heda.
So, yeah. So good evening, everyone. Thank you so much. At the outset, I would like to thank Dr. Bharti Kashyap and Jharkhand Ophthalmological Society for this wonderful opportunity, and Dr. Arvind Moria sir for recommending my name. Hats off to the efforts of the team and Dr. Bharti Kashyap ma'am. She has been continuously messaging and updating about the details of this session, and with great efforts, this session has come up. So I'm sure it is going to be a very interesting session. So I'm going to share my, this is a very interesting video of patient from Africa. I operated few years back, and I have won a couple of international awards and a few state level awards for this video. So just let me know if my screen is visible and it's audible.
No, your screen is not, now it's visible. Now it's visible.
But can you hear it?
Yes, yes.
Yes, yes, you are audible, very much audible.
Ma'am, we are not getting the audio. Can you just check the audio, please?
Okay. Just let me share it again. I've stopped it.
Aarti, it would be better to rely.
Ma'am, when you are sharing, just click the share
Yes,
sound
yes.
option on the bottom.
Rely on your own voice rather than the PPT audio.
So let's see if it works now. If not, then I will talk while I present.
Yeah, we are getting
Is
the
it any
audio now.
better?
Yeah, we are getting the audio, ma'am.
Presenting a case of 29-year-old female with a 14-year-old history of Stevens-Johnson syndrome, who presented to us with a vision of perception of light and keratinization of ocular surfaces in both eyes. Under local anesthesia, keratinized tissue and conjunctiva was excised completely. The pannus was removed. A phakic orocapro was selected for the surgery. Donor cornea was trephined and the central 3 mm of cornea was removed. Graft was then slid over the capro stem and the back plate was placed. The locking ring was placed. Host cornea was then marked and anterior chamber was entered. Corneal button was excised. Crystalline lens was removed. The assembled capro was then sutured with 16 10-0 nylon sutures. conjunctiva was opposed and sutured. Postoperatively, patient regained vision of 6/12. With strict and very vigilant postoperative care, the patient has maintained the same visual acuity over past 2 years.
So thank you, everyone.
Thank you, ma'am,
Thank
for
you,
the
ma'am.
excellent video.
Over to the brightest, Pranita Sahai. I
Thank-
welcome Dr. Divesh. Divesh is also here, na?
Yes, ma'am, is there.
उसका दिख नहीं हाँ देवेश is here. He is also a very bright young retina surgeon. He has become assistant professor in RP Center, AIMS, New Delhi. So welcome Devesh. हम
Thank
तुम
you,
लोगों का
ma'am.
इंट्रोडक्शन अच्छे से
Thank
बाद
you,
में
ma'am.
कर देंगे बेटा. बट देन अभी टाइम नहीं है, तो सबका पूजा पाठ है अभी. So over to Pranita. You have any question to Dr. Aarti Heda?
Thank you, ma'am, for the kind introduction. Indeed, Dr. Aarti, that was a wonderful surgery. As simple as it may look, it's not a really simple surgery to do a keratoprosthesis, especially in a patient of SJS where the conjunctiva is so scarred and the ocular surface is so really poor. So, ma'am, just a few questions. So, what is your post-operative regimen that you advise in these patients? For example, your BCL placement, how long do you keep the BCL? And
So thank you so much, Dr. Pranita. So basically, you change the BC. You have to put the BCL definitely. So you keep changing the BCL every month. The most important part for any keratoprosthesis patient is counseling. So if in case you know that the patient is going to visit you and patient's relative are enough motivated to make sure that patient is going to be very regular to the hospital for the follow-up, then he's probably the best candidate. So post-operatively, you start the patients with topical steroids and antibiotic and lubricating eye drop. And these patients are prone for infection, and at times it's difficult to assess their glaucoma status. So prophylactically, we start the anti-glaucoma medications and we put the patient on antibiotics. So maybe you can keep alternating between any of the two antibiotics so that the patient doesn't develop the resistance for it. So that will be, and then of course you keep changing the BCL regularly, and make sure that the patient has enough lubricants in the eye. Yeah.
Basically, lifelong lubricants and lifelong antibiotic and lifelong of bandage contact lens. So, very well educated patient is the ideal candidate. Any experience with type 2 K-pros in these patients?
No, I haven't done any.
Dr. Bharti, can I ask a question if you don't mind? Okay, one question. Aarti Jinklis ka?
No, sir.
Achha, okay. Question is, the sutures that you apply, how do you balance the sutures so that there is no tilt with the anterior and the interior part, the balancing of the weight so that there is no tilt and it remains virtually within the visual axis? Is there a keratoprosthesis or something that you use intra-op to make sure that the suture tightening is uniform?
So honestly speaking, it won't affect a lot for keratoprosthesis cases. The astigmatism, I understand that probably when you say that keratoscope, it is for that. And to stabilize the device, the formed device on the cornea, I will definitely take the 4 cardinal sutures, and I think that will be just enough. I don't know if Dr. Pranita has anything to add here.
They have intraop keratometers, intraop rings that are embedded, the red light that you see with the microscope, with which you can see actually the configuration of your astigmatism. So that can be used, but I have no experience of that with the K-Pro, whether you visualize that over on top of that, the K-Pro as well. But in routine keratoplasty, the intraop keratometers that you have in your microscope can be used very well. And also the diamond configuration that you have with the first 4 cardinal sutures to ensure that you have an equitable distribution of tissue in all the 4 quadrants. That also helps in reducing the astigmatism And the tilt, probably that's is wanting to ask about the cylinder of the K-Pro.
The question referred to was about the weight distribution in front and behind the screw.
Yes, sir.
Never mind, we're running short of time. Aarti, beautiful.
Okay. Yes. Thank you so much, sir. Thank you so much.
Now we are inviting Dr. Arvind Maurya because his presentation is SLET. This is again a cornea and surface thing, and Dr. Pranita is the discussant. After that, we will take Ankita.
Thank you so very much, Jharkhand Ophthalmic Society. It has become my second home. And a special thanks to all the chairpersons, the Chairman Scientific Committee, Dr. Bharti Kashyap, and all the moderators. Thank you so very much. So my talk is on SLAT, and this video won 9 international and national awards. Greetings, everyone. Thank you, Scientific Committee, for giving me the opportunity. I am presenting a case of simple limbal epithelial transplant in a case of alkali burn in an 11-year child complained of sudden onset, gradually progressive, painful degrees of vision in left eye associated with watering, redness, and photophobia following Lyme injury. On examination, his visual acuity was reduced to finger counting at 3 meters with 360-degree limbal ischemia, total macular haze with no appreciable anterior chamber details. For successful slide surgery, preoperatively evaluation of donor cornea from the superior limbus is a must, along with evaluation of recipient cornea, which needs to be wet with no adnexal pathology and proper assessment of corneal scarring and thickness is mandatory. Topical phenylalanine drops can be instilled to avoid any hemorrhage under the graft. Under GS, from the other healthy eye, conjunctival limbal autograft surgery was started after properly placing the universalized papillum and passing off superior rectus bridal suture for proper exposure. Then, the conjunctival flap was created just behind the superior limbus, around 2 to 3 millimeters away from the limbus, and limbal conjunctival tissue was finally dissected at 2 clock hours position, slowly and gradually up to the presumed extension size, and then it was finally excised and was kept in Bayesian salt solution, avoiding it to dry. This was followed by the conjunctival closure with the help of H0 absorbable recurrent suture. Intraoperatively, plane needs to be kept parallel to the dissecting plane to avoid buttonholing or perforation, and simiparon needs to be excised first and graft must be placed in correct orientation. Ample time must be given for glue polymerization, and before removing the speculum, glue strands must be excised. In such cases, longer follow-up is indeed needed. In the recipient un-LDI, 360-degree conjunctival peritomy was done 2 to 3 millimeters away from the presumed limbus with the help of Vanna Caesar. Conjunctival panus removal was started all around the 360-degree using blunt and sharp dissection. As you can see, it has been carefully removed all around the limbus. Now, the epithelial debulking was performed, and this was followed by careful and gentle resection or removal of the corneal epithelium, avoiding any perforation or buttonholing. Then, freshly prepared amniotic membrane was placed over the cornea with the basement membrane side up, avoiding any pores, and was cut in appropriate size all around the limbus. Then, with the help of fibrin glue, it was adhered over the cornea, first in the inferior quadrant, followed by superior quadrant, with the help of non-traumatic forceps and giving proper time for the glue to polymerize. Finally, this membrane was stuck under the conjunctiva, avoiding any folds for better results. Now, the limbal tissue was taken out from the basal salt solution and was cut into 6 to 10 smaller pieces and then placed over the membrane with the finer stromal strand side in the downward direction and the pigmented smooth epithelium in the upward direction with the help of hemostatic glue. And utmost care should be taken to place in the mid periphery, avoiding the central visual axis. After waiting a few minutes for glue to polymerize, a softer therapeutic bandage contact lens was placed over the cornea and was kept for 7 to 10 days. Post-operatively, at 3 months, the patient's vision was improved to 6 by 24 with absorbed amniotic membrane. Now, corneal gaze was substantially reduced to minimum. So, SLAT is a simple, cost-effective surgical technique which can be performed at almost every smallest of the eye care center, clearly avoiding reference to the higher centers. It is a novel treatment for management of limbal stem cell deficiency in such type of research. As we compare SLAT over CLAT, SLAT has many advantages like a very high anatomical success rate, especially in children, advantage of in vivo expansion only, and surgery can be done in a single sitting. Also, SLAT is a much cost-effective technique with rapid healing of cornea in the visual axis. So, it is an easily accessible surgical technique for the management of limbal stem cell deficiency due to chemical injuries, which is quite common in developing countries and in children. Thank you so very much for your patient listening.
Thank you so very much.
Over to Dr. Pranita.
Thank you, sir. Indeed, that was a wonderful presentation. And it's a simple surgery, but the outcomes of SLET are so really good that patient satisfaction and the outcomes improve the visual outcome in these patients. Sir, any experience of doing the recently talked about SLET without AMG? Have you tried any
AMG?
case?
No, I haven't done. I'm used to this freshly prepared amniotic membrane.
Fresh
I
AMG.
prefer this thing.
And so what's your preferred interval from the chemical injury sequelae to doing a SLET? The gap that you prefer?
Yeah, it's generally between 3 to 6 months.
6 months time is usually preferred
yeah.
because before that the inflammation ongoing.
Yeah, that needs to be subsided.
Yes. And what's your post-operative regimen in these patients, sir?
Yes, that is very important. So tablet doxy, 100 mg BD, and because it helps in the anticholinergic activity, and also a lot of vitamin C. That also helps, 500 mg BD, and along with steroid and cycloplegic. And now we have this Terigo BCL. This we have innovated. This is innovation of Dr. Kakadia sir. So it covers each and everything so well, and it can be kept even for 4 months FDA approved.
Okay. How long do you keep the patients on steroids in these situations?
Steroid on tapering dose for 6 weeks.
6.
And if, yeah.
Okay.
And
That's
a lot
good.
of lubricants.
Yes, definitely, sir. Wonderful videos and beautifully highlighted. So what is the length of the limbal stem cell or the conjunctival graft that you take from the limbus? What is the size of the graft?
Yeah, it's between 4 to, means 4 mm is the preferred, and 2 millimeter, 2 to 4.
Yes. Okay.
Yeah.
Thank you, sir. Thank you for beautifully highlighting all those steps which are crucial for success of this important surgery.
Yeah, it's a very simple surgery and the results are quite predictable.
Yes.
When we talk about the ex vivo, this limbal stem cell harvesting, so then the growth is from the periphery. But in this SLAT, The pupillary area, the everything, it starts to grow in no time. So the photophobia and all these foreign body sensation, the redness, and so the patient is very happy. Thanks to Virender Sangwan sir. Thank you so very much. And special thanks to Dr. Sheetal Mohwakar from Ahmedabad, who taught me the surgery.
Very nice. Now you are free for your puja, Dr. Pranita. Thank you so much.
Thank you so much,
So,
ma'am, for
but please do join after your puja, because there is a lot of other talks also where you can play a role of discussion, and your proper introduction is also awaited. So now we are going to over to Dr. Ankita.
Congratulations to all the ladies. Happy Karwa Chauth. Sorry, I forgot.
But you have to be here. You are also one of the discussant. Never forget that.
Anytime, ma'am, any subject.
आप अभी रहो.
जी.
हाँ, तो अभी we are Dr. Ankita Aishwarya. Her discussant is Dr. Ruchi Goyal.
Yes, ma'am. Am I audible?
But Dr. Maniyar sir and other people can be discussant also.
Okay. Am I audible, ma'am?
Yes.
Okay. So a very good evening, everyone. At the outset, I would like to thank Jharkhand Ophthalmic Society for giving this opportunity, and a very happy Karwa Chauth to all the lovely ladies there. I'll be presenting our study on super selective triple drug intra-arterial chemotherapy in retinoblastoma. Well, this study has won American Academy of Ophthalmology Best Paper Award in the year 2020. We have no financial disclosure. The management of retinoblastoma has been evolving from enucleation as the only option for life salvage in 1970s to the introduction of EBRT as a means for eye salvage. Intravenous chemotherapy, along with focal therapy, has been the treatment of choice for the past several years, even as intra-arterial chemotherapy entered the arena as a game changer. In our study, we have used super selective ophthalmic artery chemotherapy as described by Govind. Several studies have used melphalan, topotecan, and carboplatin either alone or in combination with variable outcomes and complications. While reviewing the published articles with large sample size, we observed limitations like asymmetry in drug utilization in different groups, along with the higher number of IAC cycles. We assessed the efficacy and safety of superselective IAC with a 3-drug combination. Primary outcome measures were life and eye salvage. Tumor response and complications were secondary outcome parameters. This was a retrospective interventional case series with 145 eyes of 112 consecutive patients treated between 2013 to 2019. During the study period, we had 1,300 number of patients in the active treatment, and out of them, 112 patients who received triple drug IAC was included in the study. IAC was advised as a primary for naive treatment or as a secondary therapy for refractory or the recurrent tumor. The exclusion criteria are enlisted. Our group received topotecan, carboplatin, and melphalan, and doses were decided as per the age of the child. Melphalan is prepared and administered as the last drug, owing to its shorter shelf life. 3 cycles were administered at an interval of every 4 weeks. The procedure was performed by a skilled neurointerventional radiologist. The ipsilateral carotid artery is catheterized by a transfemoral approach, and the ostium of the ophthalmic artery is identified. Each drug, diluted to 30 ml, is injected in a pulsatile manner over the 30 minutes to prevent drug lamination and loss to the peripheral tributaries. At the end, vascular patency was ensured. Coming to our results, 94 cases were unilateral. The mean age was 23 months, and the follow-up was 42 months. 63% of were primarily treated with IAC. The remaining 37% received secondary IAC following the failure of intravenous chemotherapy. Majority of our patients who received primary IAC belong to group D and E. For group B tumors, there was 100% eye salvage and tumor regression. Similarly, there was complete tumor regression in all the 16 patients with group C. 2 of them had recurrence of focal subretinal seeds, which were treated successfully with transpupillary thermotherapy. For group D, eye salvage was 92%, with 48% achieving complete tumor regression. The remaining with partial response were treated with intravenous chemotherapy or intravitreal injection or plug brachytherapy. 5 eyes had to be enucleated for no response or recurrence. Eye salvage was 54% for group E eyes, with only 4 eyes showing complete regression after IAC. Others needed intravenous chemotherapy, plug brachytherapy, or TTT. Of the 19 eyes that were enucleated, 5 were for no response to chemotherapy and 14 were for the tumor recurrence. 53 eyes were treated with secondary IAC at an interval of 6 to 18 months from intravenous chemotherapy. 96% of the eyes could be salvaged. 2 eyes which had to be enucleated had no response to the treatment. The Kaplan-Meier analysis for 5-year enucleation-free survival was 73% overall, 85% for Group D, and 53% for Group E eyes. Life salvage was 100% in our case series. Complications were seen in only 11 patients, and majority of these were transient and reversible, except for one case who had ophthalmic artery spasm. When comparing with the other large series using single or 2 drug for IAC, our triple drug combination had better enucleation-free survival for all the groups of retinoblastoma. Compared to other large studies, our study of triple drug IAC, both in primary and secondary, shows better eye salvage with fewer number of cycles and longer duration of follow-up. Complications were minimal with no long-term consequence as compared to melphalan alone or a combination of melphalan with topotecan. It is evident that secondary IAC with triple drug regime gives a superior results of globe salvage. To summarize, our study shows encouraging long-term results in a large sample of patients with protocol-based triple drug superselective IAC for 3 cycles in both primary and secondary IAC, with globe salvage rate of around 92 to 100% in Group B, C, and D, and promising results in Group E. The complications are few and reversible. Our study has certain inherent limitations of a retrospective study. ERG to assess the retinal function was not done. These are our references. Thank you so much.
So thank you, Ankita. It was, of course, the study and your work with Dr. Hunawar is commendable. And of course, all of us now agree that intraarterial chemotherapy, especially for Group D and E, it's the treatment of choice. And what is your experience? There's a lot of talk about, topotecan being used when there is more of vitreous seeding. So you generally give 3 drugs to all the patients, or you have some, if there are recurrences, you need to alter your regime. Is it always the standard protocol you're using?
Ma'am, for intra-arterial chemotherapy, yes, we are using all the 3 drugs in combination, whether it's a primary case or it's a secondary cases. Yeah, with respect to if it's not an intra-arterial chemotherapy, the child is receiving intravenous chemotherapy, then depending upon the recurrence of vitreous seeds or the subretinal seeds, then we decide intravitreal injection, whether to give topotecan or something else. But for intra-arterial, all 3 drugs combination we are using.
So what is the longest follow-up you have had after this therapy?
We have a mean follow-up of around 23 months, and longest was of around 62 months of a 3-year-old child. Yeah, we had that one.
Okay.
It was a Group D. We were able to salvage the eye as well as the.
So what would you suggest? I guess you need a very specialized system of working, because it cannot be, and it's pretty expensive to give IAC. So what is your recommendation for a country like us? What? Yeah, because not everybody would be able to afford this kind of a therapy, and not all institutions would be having it. So what is your recommendation for, as at a national level, some steps should be taken? Any recommendations?
It's a very practical thing which you have told, that IAC is actually not possible in every setup. The best at Indian scenario is definitely still intravenous chemotherapy with or without focal therapy. That is currently the best. Yeah, those who can afford, and the centers which we have, yeah, definitely we can refer the child to those center areas where the IAC is present and the patient and parents are capable of doing that.
So what is the cost for the 3 cycles of?
Okay, so actually with Dr. Hunawar sir, there was 2 categories were there. One was like where NGOs, if they participate, then definitely the cost reduces. Else it was approximately 50 to 75K per cycle it goes, approximately.
Per cycle means?
Including everything.
That means all 3 cycles or single cycle?
Single cycle, including everything, like right from ophthalmologist to radio-interventional radiologist, drug and conventional procedure.
So I guess the net, to summarize, I would rather say that this is the treatment of choice, no doubt about it. We need to really work on collaborating with the interventional radiologist and setting up these areas so that, these patients receive treatment in time and we can salvage the eyes. Thank you so much.
Agree, ma'am. Thank you.
Dr. Ankita,
Yes, sir.
very nice talk as usual. So now coming to the plaque brachytherapy. So what are the indication in which you prefer this plaque brachytherapy, and what are the long-term follow-up. So these are my two questions for you.
Okay, sir, plaque brachytherapy with respect to retinoblastoma?
Yes, of course.
Yeah, okay. So in retinoblastoma, sir, plaque brachytherapy, mostly we are using in cases of secondary IAC, like secondary cases where the primary we have either used IVC or we have used IAC and the child has recurrence, then we go ahead with the plaque brachytherapy.
And in terms of long-term follow-up, so
Yes,
any
sir.
recurrence?
Okay, so in plaque brachytherapy, actually, say it totally depends. If the tumor recurrence is there, then we haven't, well, we have hardly seen 1 or 2 cases who have recurred. But in cases of seeds, if it is there along with the main tumor, then definitely there are chances of recurrence where we have to give intravitreal along with the plaque brachytherapy.
So what is the future, near future, the best innovative treatment modality according to you?
Intraarterial chemotherapy.
Right. Thank you.
Thank you, sir. Ma'am, I have my other presentation also. Can I just complete it now? Can I go ahead with the second presentation?
Yes, yes, Dr.
Yes, please go ahead.
You can
Please
please
go
go
ahead.
ahead with your second presentation.
So this is a video. So is it audible?
Yes, you are audible. You are audible.
By which all the intraocular contents are removed while preserving the remaining scleral shell, extraocular muscle attachments, and the surrounding orbital admixture, followed usually by the placement of an orbital implant to replace the lost ocular volume. The various indications are: malignancy is an absolute contraindication to evisceration. It is imperative that an intraocular malignancy must be ruled out either by slit lamp examination, fundus evaluation, or B scan before recommending the procedure. Evisceration is an evolving surgery which was introduced in 1817 by Beer in expulsive hemorrhage case. Noyes in 1874 introduced this procedure in intraocular infection case. In 1884, Mules further enhanced the cosmetic result by placing a hollow glass sphere within the residual sclera to add the volume and support. Now the question comes, how to calculate the implant size? First step is to measure the axial length of the contralateral normal line. Let us take it for example, 24 mm. Second step is to calculate the circumference by formula pi d. Assuming that the pi is simply 3, so for 24 mm axial length, the circumference will be 24 into 3, that is 72 mm. In the third step, subtract the diameter of the cornea and the limbal tissue that are removed in the evisceration from circumference. Example, assuming the cornea to be 11 mm and removing 1 mm of limbus. So we subtract 12 mm from the circumference. So we are now left with 72 minus 12, that is 60 mm of the available circumference. In the fourth step, we divide it by pi or 3. So we end up with a possible implant size of 20 mm. For final implant size, we subtract by 2 mm to allow 1 mm of sclera on either side for suturing, as we don't want a tight suture. Implant is not sufficient enough to restore the volume and most likely to leave in-ophthalmos even after the surgery, then this won't work. And hence came the era of sclerotomies. The basic principle of any sclerotomy is either a radial or equatorial relaxing incision with or without optic nerve disinsertion. It all began in 1987 when Stephenson performed multiple radial expansion sclerotomies as well as posterior spiral sclerotomy. In 1997, Jordan and Anderson described disinserting the optic nerve and performing small radial sclerotomies. In the same year, Yang et al. Described scleral quadrisection technique. In this technique, the native sclera is quadrisected from the limbus to optic nerve between the rectus muscle insertion with the optic nerve intact. In 2000, Long et al. Reported a transscleral evisceration technique in which the posterior sclera is opened and an unwrapped orbital implant is placed behind it in the intracoronal orbital pad. In 2007, Sales Sands and Sands Lopez they described the 4-petal technique. This technique divides the sclera into 4 petals, each with one of the rectus muscles. The optic nerve is cut. In 2010, George popularized equatorial sclerotomy technique. In this video, we demonstrate evisceration in a 39-year-old male with a painful blind eye following trauma. We use the novel circumferential complete equatorial relaxing incision technique in this patient to allow for a larger implant with anterior placement and thus preservation of the orbital volume. Step 1. Peritomy. Care is taken to preserve as much conjunctiva as possible. In our case, conjunctiva is adherent temporally, and so peritomy is done last in that area and carefully. Dissection of the conjunctiva is very crucial to retain the optimal ocular surface and the fornical depth. The scissors are held parallel to the conjunctiva to get as close to the limbus as possible, and a non-tooth forceps is used to prevent the conjunctival damage. Step 2. Removal of the corneal button. A full thickness limbal incision is made with 11 number scalpel, and the remainder of the limbus is cut with scissors, allowing for the removal of the corneal button. Step 3. Removal of the intraocular content. Create a small crevice between the rim of the sclera and the ciliary body, and then using a evisceration scoop, gently separate the sclera from ciliary body 360 degree. In one careful posterior sweep, the rest of the uveal tissue is separated from the sclera and removed en bloc. Step 4. Clean the residual. Carefully inspect inside the sclera and remove the bits of residual uveal tissue. Uvea may be densely adherent to the sclera in the areas of chorioretinal scar, at the site of perforating nerves and vessels, and around the optic disc. Step 5. Alcohol denaturation. The inner surface of the sclera is then scrubbed twice with the absolute alcohol on the cotton tip applicator. This process will remove the adherent uveal tissue or denature what cannot be removed, and thus will minimize the theoretical risk of sympathetic ophthalmia. By doing this, we avoid the spillage of alcohol to contaminate the conjunctiva. Step 6. Removal of the residual alcohol. The scleral cup is irrigated with 20 cc of ringer lactate to wash out the alcohol residual, carefully avoiding the conjunctival spillage. Step 7. Hemostasis. The inner surface of the sclera is inspected for persisting bleeding points, which are gently cauterized. Step 8.
Liver tissue
Sclerotomy.
subtractive vascular, no? So hemostasis
All
of the
arterial
mass.
sclerotomy at the rim is performed to allow the entry of the implant. The optimal implant size in this patient was 16 millimeter. However, even a 15 millimeter implant was tight. So we proceeded with a complete equatorial relaxing incision. While making this incision, we cut by lifting up the sclera to minimize the damage to extraocular muscles, and we avoid the vortex vein to minimize the bleeding. We completed the incision to divide the sclera into two halves, larger anterior and a smaller posterior half, without disinserting the optic nerve. Now we were able to place a larger silicone implant of 20 millimeter, and it fits easily. Step 9. Closure. Scleral rim is sutured with closely placed 6-0 vicryl interrupted sutures. Winging at the edges is turned onto the surface and is natural directed and sutured. Conjunctiva is sutured with a continuous key pattern sutures with 6-0 vicryl. A snugly fitting and a well-centered conformer is placed, and suture tarsorrhaphy is performed and left for a week. The implant motility is optimal at 6 weeks. The custom ocular prosthesis matches with the contralateral eye in static and dynamic cosmesis. In summary, the complete equatorial sclerotomy technique is a simple procedure that allows for the placement of a stable and an optimally sized implant following evisceration in the setting of an atrophic bulbi or thysis bulbi.
So, Aishwarya, as usual, a very beautifully done surgery and a bloodless surgery. And I agree with you. All of us basically are using this technique more or less with slight bit of modifications, because I think most of the patients who come up finally for cosmetic surgery for these thysis or atrophic bulbi eyes, they would require some kind of expansion, some kind of release. So it may be, what this modification or doing it at the equatorial region, of course, it has added to, your innovation. And just to add that, basically, I don't know, somehow sizing beforehand, we used to do it quite routinely, but it never works out because on table, most of the time you find that what you were actually planning to put in, even the sizes don't work. So really, taking so much time off to measure the excellence, do all those calculations, I don't know, I don't find them practical at all and kind of have stopped using them. Because you may be planning for 20, 21, 22, and you end up putting just 16, 18 implants. So what is your take on that?
Yes, ma'am. A very practical thing to actually face on people. So that is why I think the era of the sclerotomies have come, and that's why we keep a range of wall implants. Whatever the size is coming, at least that is there, and also plus minus whatever the 2 or 3 millimeter implants we always keep. Even with the sclerotomy, if we are unable to keep put that, then that's a different issue. But with sclerotomy, we are almost able to achieve whatever we have calculated in almost 80 to 90% of the cases, ma'am.
And sometimes, you may have a very large globe.
Yeah.
Sometimes they rise with it. So you need to actually trim the sclera down rather than putting the. So again, on table sizes are also not of much help because again, you end up in a asymmetry if you just follow that principle. So yeah, very nice video and yeah, and nice innovation. Thank you.
Dr. Aishwarya, you did this surgery?
No, sir, it was Dr. Honavar, sir. I was his fellow.
Okay, very stable hand and
Yes, sir.
a treat to watch, always.
It's always
Thank you.
a treat to watch, sir. Thank you so much, sir. Thank you.
Thank you, Dr. Aishwarya. Next, I would like to invite Dr. Kirandeep Kaur for her video, and she will be showing us the video on demystifying the role of artificial intelligence in pediatric ophthalmology. Over to you, Dr. Kirandeep Kaur.
Am I audible?
Yes, you are.
Yes, you are audible.
Okay. Thank you so much, Maurya sir, for the kind introduction. At the outset, I would also like to thank Jharkhand Ophthalmic Society and Dr. Bharti Kashyap madam for this recognition. And again, Dr. Arvind Maurya sir for the recommendation. So I'll be sharing this video that I presented in APOS 2024. So this video is basically focusing on the role of artificial intelligence in pediatric ophthalmology.
Role of AI in Pediatric Ophthalmology by Kirandeep Kaur Bharat Gurnani. The growing accessibility of ophthalmic data, combined with progress in artificial intelligence and machine learning, holds the promise to revolutionize clinical practice. Machine learning methods, when applied to general ophthalmology, have shown promising capabilities in areas such as automatic disease identification, preliminary screening of primary care patients for specialist consultations, and contributing to scientific research. Serving alongside ophthalmologists, these and upcoming applications hold the promise to enhance patient care, cut down expenses and access hurdles, minimize unwarranted referrals, allow for consistent monitoring, and facilitate early identification of diseases. Special considerations in pediatric eye care. The prevalence, causes, symptoms, diagnosis, and treatment of eye diseases vary significantly between adults and children. These differences are crucial to take into account when designing artificial intelligence applications. Children often experience conditions such as amblyopia, strabismus, blocked tear ducts, also known as NLDO, ROP, and inherited eye disorders. Glaucoma serves as a prime example since the origin and symptoms in congenital glaucoma patients differ significantly from those with adult-onset glaucoma. Retinopathy of prematurity. In the field of pediatric ophthalmology, the most notable AI advancements relate to ROP, a major cause of childhood blindness globally. Initial efforts to detect plus disease in fundus photos centered on the measurement of vessel tortuosity. One pioneering method sought to measure tortuosity through the spatial frequency of hand-drawn vessel traces. Since that time, multiple tools like Vessel Finder, Vessel Map, ROPTool, RISA, CAIAR, and IVAN have been introduced. However, newer techniques for identifying ROP and plus disease predominantly utilize convolutional neural networks, CNNs. Systems such as those by Wuerl et al., IROPDL, and DeepROP employ this approach. These CNN-based methods analyze fundus photos directly, eliminating the need for manual annotations. Improvisation potential. While existing ROP detection techniques can differentiate between severe and mild ROP, they don't provide detailed insights into the disease's stage or zone. Only systems like DeepROP and MeGraph consider more than the posterior pole view, with others either neglecting or purposefully omitting alternative views. Even though research indicates that severe conditions rarely occur without posterior pole vasculature changes, offering a more comprehensive breakdown of the disease's zone and stage might enhance the system's clarity and effectiveness. Insights into pediatric cataract. Cataracts in children are more varied than in adults, influencing the decision to surgically remove them based on their severity and the risk of vision impairment. The CC Cruiser is a cloud software that can identify cataracts from specialized eye images, classify them, and suggest possible treatments. It first adjusts the image to focus on the lens, and then utilizes 3 distinct convolutional neural networks, based on modified AlexNets, to determine if a cataract is present, grade its characteristics, and advise on treatment. When tested in a comprehensive study across 5 eye care clinics, CC Cruiser's accuracy in detecting cataracts and suggesting treatments was 87.4% and 70.8%, respectively, which is lower than human experts who scored 99.1% and 96.7%. Insights into strabismus. Strabismus affects 1 in 50 children and can cause amblyopia, interfere with binocularity, and have lasting psychosocial effects. A CNN was used to detect strabismus based on visual manifestation in the eye regions of facial photos, which would be especially useful for telemedical evaluation. For in-office evaluation, which in contrast permits the use of specialized screening instruments, strabismus can be detected using a CNN based on fixation deviations from eye tracking data or with very high sensitivity and specificity from retinal birefringence scanning. Insights into vision screening. Strabismus and refractive error can both lead to amblyopia, and unfortunately, they're not easily detected by pediatricians. To address this, experts recommend instrument-based vision screenings. Most of these instruments can be adjusted for signaling when there's a potential issue. Van Eenwyk and colleagues utilized video frames from a device that merges Bruckner pupil red reflex imaging with eccentric photorefraction. They trained several machine learning models to identify risk factors for amblyopia in young kids. Of these, the C4.5 decision tree stood out as the most effective. Insights into myopia. High myopia can lead to severe vision problems. To prevent or slow down its progression, children who are susceptible to high myopia can be given low-dose atropine. However, deciding which children should receive this treatment can be challenging. A study by Lin et al. Used a random forest to forecast high myopia in children based on clinical data, providing reliable predictions for as long as 8 years ahead. Continued research in this area may assist in guiding preventive treatments. As AI becomes essential in pediatric eye care, it's crucial to address ethical concerns, data protection, and the clarity of algorithms. It's imperative for AI creators, ophthalmologists, pediatricians, and regulatory agencies to work together to guarantee the safe and conscientious implementation of AI solution. By refining early detection processes, boosting diagnostic precision, and tailoring treatment plans, AI is reshaping how we approach children's ophthalmology. As we journey through this promising era, harmonizing human skill with AI advancements is essential to ensure a more promising future for young individuals facing visual difficulties.
So excellent presentation, Dr. Kirandeep, as usual. So now coming to AI, how much more, or how much lesser is it the future? Because now it's rampant use in the screening, diagnosis, as well as the treatment modality also coming up. So regarding our job, in future, ophthalmologist, will it be obsolete?
Sir, that is never going to happen. So ultimately, human mind can never be overcome. So it is just basically the incorporation, like as we are growing ahead. So we need to use the artificial intelligence and its capabilities to enhance our capabilities. That is the main thing. So we need to, the ultimate thing is like as we involve artificial intelligence into the regular practice, we can definitely improve the diagnosis and the treatment aspects of the patient.
And now coming to, there are different versions like the semi-supervised and totally unsupervised. So what is your take that which one is better and why?
Sir, I'll definitely go for the semi-supervised one. In unsupervised, because we cannot, because when we are treating the eyes, it is like any human thing. I mean, it is ultimately that is going to be like cost a human life or a human sight. As ophthalmologists, we should be talking about the human side. So any minor error also can lead to a big mistake. So definitely a semi-supervised will be my go for sure.
Thank you. Now coming to the validation part, I was going through the literature. So there are more than 7,000 AI-based applications that are relevant to ophthalmology. But when I checked the validation part and the trials, so only 4% are there. So that is a little bit scary.
So that is where we actually need to focus in, because there is a lot of development when we are talking about the new applications coming in or the new technologies coming in. But as you said, the validation part is strictly lacking. And that is, I feel, where we as ophthalmologists play a very major role. Like we need to keep a check in, like the quality check has to be maintained. That is not happening at present. So that is definitely a major lacking at present.
So I think in near future, we need to have some SOPs governed by the Ministry of Health and Family Welfare in our country. Thank you. Thank you, Dr. Kiran.
Thank you so much.
Just one question, Kiran. What about suppose a mistake is made by the AI? So who is held responsible? The doctor or the company?
Ma'am, like since as a human face, we are the first person who is like who is recommending like anything to our patient. So definitely, if we need to keep a check, like that is what is where the validation part is really important. So before we tell anything to the patient, or when we are using all the AI based programs, we need to be really sure what how much we are incorporating this, and it should never be like totally unsupervised. We cannot be relying 100% on these AI models. Definitely a cross check has to be needed, like for example, for ROP screening, whenever there is a positive or a negative, ultimately in the end a human has to keep again a cross check over the like to ensure like whatever results are coming, we should not be missing something. Gross errors should not be happening.
Thank you.
Thank you, Dr. Kirandeep, for your excellent video. Now I would like to invite Dr. Devang and Mo, and he would be showing his video on primary angle closure disease, PACD.
She,
Oh, sorry,
and,
Dr.
and discussion for Devang is Anindya Anuradha. Anindya, are you present?
Yes, ma'am. Good evening, ma'am.
Good evening, good evening. For the
Ma'am, is my slide visible?
Yes, yes, very nice.
Yes, you are visible and audible too.
Yeah. At the outside, I would like to thank Jharkhand Ophthalmological Society and Bharti Kashyap ma'am for inviting me. So the title of my talk is Paradigm Change in Primary Angle Closure Disease Management. And for this, I had received the APGS, that is Asia Pacific Glaucoma Society Young Investigators Award 2024 for my research in angle closure and imaging in glaucoma. So basically, when we see there's a paradigm change in the angle closure spectrum. The primary angle closure suspect we have, then we have the primary angle closure, PAC, and then we have the primary angle closure glaucoma. So what is important is that our part of the continent, angle closure has a lot of burden. And from yes to PAC, nearly 30% they progress, and from primary angle closure they progress nearly 30% to angle closure glaucoma. So this we have to keep in mind. And for the new classification is the ISGO classification, which says that the occludable angles are basically those in which iridotrabecular contact of more than 180 degree is seen, that is known as suspect. And if there is evidence of angle closure, evidence of peripheral anterior synechiae or
excuse me, Bharti ma'am, please mute yourself. Thank you.
We refer to it as PSC. And if along with the PSC, if these two criteria, we have a raised IOP, we now classify it as PSC with ocular hypertension. And if there are corresponding optic nerve head and visual field changes along with them, it is considered as primary angle closure glaucoma. So the first and foremost thing is in PACS, which is primary angle closure suspect. These patients we never treat. Basically, we need to regularly follow up. So the only indication for treatment is that if they have an established fellow eye of PAC or PACG, or they have a family history of PAC, or they cannot come for regular follow-up, or they require a frequent pupillar dilatation in view of some retinal pathology like diabetic retinopathy, or there is a positive provocative test. So only in those cases we do a peripheral laser iridotomy. We never do a prophylactic laser iridotomy in these cases. Then next part of the spectrum is the PAC. In this, again, after doing a laser iridotomy, our target is to have an IOP less than 18 millimeters of mercury. And it has been noted that nearly 20% of those patients which has raised IOP even after an iridotomy, they tend to progress. And these patients are usually noted to progress after 10 years. Maybe they're using steroid use, they have a very small optic nerve head, and various Valsalva maneuvers, like in patients doing yoga in our part of the country. And so in these cases, we have seen that doing a laser peripheral iridotomy, there is a significant widening of the angles after doing the laser peripheral iridotomy, and definitely it is therapeutic in doing these PIs. We have also seen a role of the lens in these patients. In primary angle closure disease, it has been seen that the lens are usually thickened and they are relatively anteriorly placed, which causes more of an appositional closure even after an iridotomy, because the anterior chamber becomes very crowded. And therefore, we have seen that 1/3 of the PAC eyes with ocular hypertension tend to develop primary angle closure glaucoma. And in patients in whom PI has been done and still the IOP is not controlled, and you see a thickened lens, removing the cataractous lens is basically therapeutic in such patients. So this is the study from our center in which we had seen that removing the crystalline lens was therapeutic. And what we had seen, there was a direct correlation between the lens thickness and the change in IOP, the reduction in IOP. So patients having thicker lenses had definitely higher change in IOP. So this was another set of patients in which we had seen the change in intraocular pressure and angle status in patients with primary angle closure hypertension. And we had seen that after doing a cataract surgery in these patients, basically who had already undergone laser PA, there was a significant widening of the angle, and there was a significant opening up of the ITC, that is the iridotrabecular contact, and reduction in number of medications. The third part of the spectrum is the primary angle closure glaucoma. So even after doing a LPI and medical management in these patients, we had additionally undergone mixed procedures like goniosynecolysis along with the cataract surgery. And we had seen that the strongest predictor for the decrease in IOP was not only the higher baseline IOP, but also the high lens thickness to axial length ratio and a higher lens vault. So a reduction in IOP would be higher in patients with a higher baseline IOP and a higher lens vault. And so goniosynecolysis is basically stripping of the peripheral anterior synechia. So this is just a small video clip in which basically after doing a cataract surgery and angle closure, you can actually see the anterior chamber details. So here on this side, we can see a thick broad base pass, and we are just sweeping a blunt 23 gauge cannula or an iris depositor and gently sweep it, and we can see the PAS to be falling back and the angles are widening up. So this is how we use the anterior segment OCT, which tells us what the lens thickness is and what is the this is the lens vault, which is basically very thick in this case. It is nearly 1.12 and the overall lens thickness is 5.4. So what points that need to be kept in mind is that in cases of primary angle closure, these patients are often hypermetropic with narrow palpebral fissures and shallow anterior chambers. These patients should, they have posterior synechiae and very rigid non-dilating pupil, which are and also have a compromised endothelium. So there's a high risk of possible intraoperative and postoperative complications, and therefore surgery in such cases demands surgical expertise. What is more important is that biometry should always be considered while doing such procedures in patients, because it has been seen that exaggerated lens fault and increased lens thickness to axial length ratio in those patients, there is a maximum benefit of doing a cataract surgery. So in cases of severe PACGs, along with cataract surgery, where we know that the cupping is advanced, so doing a phacoemulsification will not be very good. So we have done the procedure, a mixed procedure known as endocyclophotocoagulation, and we can see that there is a significant widening of the angles, and it has been shown that both phaco and phaco-ECP associated with significant reduction in IOP, but at 12 and 24 months, there was a significant reduction in IOP in the phaco-ECP group, and also the reduction in the number of medications. So patients were using nearly 4 medications. They have reduced now to 1 or 2 medications for them. And lastly, for a very advanced glaucomas, we always resort to a trabeculectomy. But for angle closure glaucomas, what is the difference in the trabeculectomy is that we have to use releasable sutures to maintain the anterior chamber postoperatively. So the releasable sutures have actually improved the outcomes of trabeculectomies in our patients. And just to summarize that PACS patients, we tend to just follow up and explaining them the risk. In the PAC, we want to do some PI and also follow them up regularly. But in PAC OHT, you have to actually see the biometry, the aosity, and see what is the probable cause and tackle that. And in angle closure glaucoma, if it is not medically controlled, you have to actually now consider the patients for various surgeries as mentioned. Thank you for your patient listening.
Over to Dr. Anindya Anuradha.
Yeah, Dr. Devang, it was really a very nice and comprehensive presentation for the angle closure disease. So, and it is very useful, as you have said. In India, especially, this angle closure is very common. Would you please like to explain your experience having angle closure and open angle together in the mixed case? So, how is your approach?
Like having both, like a mixed mechanism glaucoma?
Yes, mixed mechanism glaucoma.
So, ma'am, mixed mechanism glaucoma is usually similar to that of a open angle case. After doing a PI, the angle slightly opens up. But again, as I've told you, if even after doing a PI, there's a persistent rise in IOP, so then we have to investigate for what is the cause behind it.
Yeah, that is what, I expected to highlight, that yes, this mixed mechanism does persist. We should not be, going in one direction. Okay, we are dealing with a chronic angle closure only. Mixed is also possible. So our thought process has to. So that's very nicely you explained. Thank you, Dr. Devang.
Thank you, ma'am.
It's a very good
Thank you, ma'am.
study.
Thank you.
Dr. Devang, I have a small question. You talked about endophotocoagulation. Could you please kind of slightly elaborate on that?
So endocyclophotocoagulation is basically doing it's an intraoperative in vivo. We use a endocyclo probe, and after doing a phacoemulsification, we have to actually form the sulcus with a high viscosity viscoelastic like Helon GV. Once it is formed, we take the endoscopic probe, which are of various sizes, 21 gauge, 23 gauge, and we directly look at the target the probe onto the ciliary processes, and it's basically it is like doing a diode laser cyclophotocoagulation under direct visualization.
So you go from the corneal route or pars plana route?
Yes, so we are anterior segment surgeons, and I usually prefer to do it anteriorly from the same phaco incision that I have done. I've done a phaco, and after that, from the same phaco incision, I put the probe and do the surgery. So it additionally takes only 5 minutes after the phaco.
So which means you like temporal, the superior temporal or the mid superior? You prefer the
So
same?
so from the temporal incision, I do a temporal incision for phaco. And depending on the severity of the disease, like most of our patients that we have are severe glaucoma. So I tend to do 180 degrees minimum. So from the same port, I can at least do 180 in one go. But in cases of very severe patients, I've done incision on the other side, opposite side, and done 360-degree also.
So in terms of long-term followability, which means mix and match of these surgeries works well?
So long-term in ECP, we have nearly around 2.5 years follow-up, and patients have whom have responded. They the medications have reduced from 4 to 2 or even 1 medications, and they have, and the decrease in IOP is persistent till now. It has not reverted back.
And madam, tell me one thing. You have to set the parameters for the photocoagulation. So
Yes,
what are the
yes.
parameters? Is it all one parameters for all, or different parameters for different situations?
So there's a standard parameter which the company gives. It is 0.2 watts. But this 0.2 watts will only work for patients if the ciliary body is very healthy. In our patients, in our range of patients, we have seen the laser between 0.2 watt to 0.4 watt. And in patients who have very atrophic ciliary body, even we have gone up till 0.6 also.
And you have to see the duration also. You have to see the distance also.
So distance is basically you're directly there's a laser beam. Once the ciliary processes, the laser beam is focused on that. It's like while we do a YAG-PI, the laser beam should be focused on the ciliary processes. Once it is focused, it is on a continuous mode, and it is a sweeping action. So if time would have persisted, I would have shown a video for the same. But because it was a limited time, so that's why I deleted the video.
Now we got the concept. Thank you so much. Fantastic.
Welcome, sir.
Thank you.
So thank you, Dr. Devan. So now we are taking up Dr. Prasanna. And the discussant is Dr. Anindya Anuradha. Anindya, you are there?
Yes, ma'am, I'm very much there.
He has joined us.
They are all international prize winners.
Rashi.
And
Rashi
I hope
Shan.
everybody is enjoying.
Yeah, Dr. Bharti Rashi
Yeah,
has joined
it's a wonderful
Rashi is
session,
there,
ma'am.
and welcome Rashi. Dr. Rashi is a very prolific glaucoma surgeon, and all these two presentations are glaucoma. So Rashi can join in as discussant also. She's the session coordinator, but she can join. Yes.
Thank you, Bharti ma'am, and the whole Jharkhand Ophthalmic Society for the opportunity. I'm going to play the video of mine, which is on MIGS. It's a teaching video, so I'm just playing the video. Let me know if the audio is heard or not. Yeah.
The iStent Video Cassette Pedagogy, an innovative teaching guide for MIGS platform. The G1 series. The glide, the ideal implantation technique. Before implantation, it is imperative to identify the angle structures. Here, we are implanting the G1 iStent into the trabecular meshwork with a proper gliding technique to ensure the proper placement within the angle. Following which, we can release the trocar and assess the stable placement of the iStent within the trabecular meshwork. And a functioning trabecular outflow system can be seen by the blood flow within the collector channel from the position of the iStent. The cheese wire, the management of trabecular meshwork cheese wiring. Every trabecular meshwork has a different consistency. Here we have a case of a very friable trabecular meshwork which cheese wires on the multiple attempts for implantation as seen here. With every reattempt, the trabecular meshwork gives away. So we had to change our maneuver into a more firm and forced glide into the trabecular meshwork for a proper implantation and a stable placement of the iStent. The nudge, confirming the position of the iStent implant. Here we have another case of the G1 iStent, which is being implanted into the angle with a proper gliding technique. Following which, we are not able to identify the positioning of the iStent within the trabecular meshwork as shown here. In such cases, with slow and controlled maneuvers with the dialer as shown here, the iris can be nudged gently to identify the scleral spur and identify the position of the eye stent within the trabecular meshwork. The rebound. Tackling the eye stent rebound due to trocar malfunction. In this case, following the successful gliding implantation of the eye stent into the trabecular meshwork, due to the trocar malfunction, the eye stent rebounds during the opening of the claws of the trocar. So, to properly reattempt an implantation, the eye stent was retrieved using the trocar. And keeping in mind the trocar malfunctioning, the eye stent needs to be released in a proper and controlled fashion as shown here. Once inserted, the claws needs to be opened completely before retrieving the trocar. Following which, the eye stent can be gently tapped to ensure its stable positioning. G1 implant plus Kahook dual blade goniotomy, the combined MIGS. Here we have a case of an G1 eye stent implantation, which was successfully implanted into the trabecular meshwork. Following which, an additional MIGS procedure was performed, the Kahook dual blade goniotomy, on either side of the implantation at least 1 to 2 clock hours apart to increase the outflow via the trabecular meshwork. G1 implant plus band, combined MIGS. Similarly, in this case, with the implantation of a G1 eye stent, an additional MIGS procedure was done. Here we did a bent ab internal needle goniectomy on either side of the implant at least 1 clock hour apart to ensure an additional outflow via the trabecular meshwork. The G2 series. Dimpling and blanching. For proper placement of the G2 eye stent, we need a proper dimple at the angle, depicting good firmness to ensure that the eye stent is well placed within the trabecular meshwork. And additionally, a second eye stent is placed in the similar manner at least 1 to 2 clock hours apart. Here we can see the two eye stents adjacent to each other via the limbus. And additionally, we can see an area of paralimbal blanching which depicts a successful outflow. Lost but found. Correct method for retrieval of dislodged eye stent. In this case, due to improper dimpling technique, that eye stent was implanted superficially. And hence the eye stent was dislodged. Continuing the procedure, a second eye stent was implanted with the proper dimpling technique. Following the implantation, an eye stent retrieval was done by rethreading the eye stent via the trocar. But as the sleeve of the trocar was not completely closed, when removing it out of the wound, the eye stent was lost. As we can see here, it is an empty trocar without the eye stent. The eye stent was found within the corneal wound. And again, a reattempt at retrieval was done by a rethreading of the eye stent into the trocar. And this time, there was complete closure of the trocar by the sleeve before removing it out of the eye. And here we can see a rethreaded eye stent in the trocar. Following which, the second implantation of the eye stent was done with proper dimpling technique, ensuring that the eye stent was well placed within the trabecular meshwork. Here, the data shows adequate reduction of intraocular pressure post-operatively. Practicing in the ophthalmic metaverse, the novel 3D simulator. With the use of hand tracking in the HoloLens, a simulated training module can be created. The 3D eyeball model gives a real-time simulation of the angle structures to practice the implantation of the eye stent. During the simulated training on proper implantation of the eye stent in the trabecular meshwork, the indicator lights up as green. And this training improves the agility of the doctor for implantation of the eye stent in the angle. Thank you.
Wonderful, doctor. So what we can see that when we are taking out this eye stent, the sleeve has to be closed. Otherwise, there is a higher chance of losing our eye stent in the eye. Very well explained. So would you like to explain a little bit on trocar bias?
Yes, ma'am. Thank you once again, Arvind sir, Bharati ma'am, for the opportunity. Ma'am, so when generation 1 was started, where we have to manually implant the stent in a tangential manner. So sometimes there is a scenario where the polarity of the stent tends to be attached to the trocar itself, where you may end up finding it difficult, as I showed in one of the videos, where when we were trying to release the claw, the stent again tries to come back to the trocar itself. So that is one is what we commonly see in generation 1 implants. And another thing is, to an extent, if there is extensive pressure on the left hand as well, though there might not be any trocar bias, but the gonioscopy hand that we use with our left hand, if we are giving more pressure, that time also sometimes I've noticed in certain cases in the early stages where the release will be slightly difficult because the diameter of the Schlemm's canal tends to collapse. So these things were the reasons why the company has now gone to the generation 2, or if not generation 3, the eye stent inject W, where in those scenarios, what happens is, again, in generation 2, if this is going to be the hole, the needle was slightly more in the front. So in that, if we are slightly tilting it has to be exactly in the center like this. If we are going to be this way or that way, so once when we puncture into the trabecular meshwork, and then we are going to be slightly like this or that. So we have to be exactly straight when we are implanting. Otherwise, if we are slightly this way or that way, then the stent will not release, because it has to have the exact diameter where the trocar has to be in the center. That is for generation 2. So the feedback that the surgeons we have given, they have now come with the Infinite, where there is minimal amount of trocar bias, because you don't see that much happening, because what from inject it was like this, where you can see the needle slightly in the front, but now in generation 3 they have covered it. So even if we move slightly to the left or right, it doesn't really make a difference, ma'am. That is the
Yeah, definitely. Yeah, it's a very good point that you pointed out. The new generation is really helping in this regard. So if this trocar bias you can add in your this video also,
Yes,
it will be really of help for the special the second generations. It's of like a great use to understand the trocar bias. Very well presented. Thank you.
this
Dr.
video.
Anuradha, there's a question from me. Dr. Prasanna, beautiful presentation and even better recording system. I must congratulate you on that.
Thank you.
Now, I just wanted to put one query. When you are using it with the bag, like a combined procedure, how often do you face problem with hyphema? And suppose you have problems with insertion or insertion in the wrong place, and there is hyphema beside it, then how do you manage it?
Yes, ma'am. To the first part of the question, so this was a video which I submitted a year back in APAO, ma'am. Now the collections are much better with the Inject W, and this was presented in Bali, where it won the award. So slightly it is outdated, but we are coming up with the other versions in the next year. And to add on to the further questions, ma'am. So now with a single stent, that is generation 1, the IOP control was not very favorable for the cost for the millimeter mercury drop that we were getting. So that is why I had to make sure that I gave 2 clock hour difference gap and made a bang on or KDB. It was an excisional goniectomy along with a stenting device that was being done in certain select patients. Then when an IFEMA happens, as you rightly pointed out, ma'am, so to prevent it from happening, the head has to be slightly above the heart. So we need to make sure that we had the table is such a way that way, or maybe have 2 or 3 pillows, so that the bleeding is as minimal as possible. It can be actually prevented with a simple head end elevation during the procedure, followed by a head tilt. But having said that, if it has happened, despite that, then I strongly believe in using super viscous like Helon GV Pro. No financial disclosure. With Helon GV Pro or other super viscous fluids, what happens is it is like a bolus. It just dissipates the bleeding away, and it just makes sure it secures the field of surgery. Even in I'm having videos now which I'll be sharing later. I mean, I'm getting it ready for the next set, where even if a stent drops with a super viscous, you will see that it just holds there. It never falls onto the root of iris, or it never gets lost. So to me, it's so fascinating to see that with super viscous, even if a stent drops, it just stays there, because the cohesive nature of the super viscous fluids are such that it helps you dissipate the hyphema. It doesn't prevent the blood coming, as well as it even holds a dropped stent. And this combined mixed procedures, ma'am, now it is one of the things people name it as mixed MIGS or combined MIGS. As my previous speaker was also saying on ECP, it is only days ahead that we were all handling the sclera for glaucoma. But the matter of fact, the aqueous production is from the ciliary body, and the aqueous drainage is through the trabecular meshwork. It is only a matter of time that we go to the anatomy of production, which is the ciliary body, and anatomy of drainage, which is the trabecular meshwork, to really tackle glaucoma with combined mix or mix and mix.
Thank you so much, sir.
Excellent presentation, Dr. Happy, as usual. So proud of you.
Thank you for the opportunity, sir.
Can't we have this preloaded injectable system controlled for this stent?
Yes, sir. Sir, the company gives us 4 clicks, sir. 2 stents, 4 clicks in preloaded scenarios, where we get 4 chances to place those two stents. So that is where even if we drop it, or even if there is a trocar bias, we always have another extra 2 chances. In one of my videos, if you had seen, the denting was not given that well. I just superficially implanted, it fell down. So
yes,
when you make a mistake, make sure you go with more pressure, and then get your second one secured, and then go to the one that we drop. So we get four chances to place the 2 stents. Yes.
Dr. Maniar, sir. Yeah. Dr.
Yes.
Maniar, sir.
Listen, I'm very keen about the
Yes, sir.
simulator that you showed.
Yes, sir.
When is it available, and what is the
yes, sir.
duration of training, etc.?
Yes, sir. So, sir, the trabecular meshwork is a structure that we never get to dissect in a cadaveric eye, or as well as in a enuclear eye, which comes for research, or even the simulation models that we have doesn't have the trabecular meshwork per se. So that is why we wanted to make a simulator for MIGS because of the cost involved in the simulation. So we wanted to make sure it to be a cost-effective one. So all tertiary eye care institutes and teaching institutes have their own simulators, such as Oculus or their HoloLens. You can name it whatever it is, because it's part of their curriculum that an undergraduate college has to have a simulator. So we have made an application for the simulator, which is quite tedious in its own way, where you saw that we have made the coding in such a way that you can go in, and once you download our application called the IMG Holo, you can train on the simulator with just an app that we have made, with where you can develop your hand-eye coordination, because the size of the trabecular meshwork is as small as your fingerprint size. So the idea is to orient yourself into the high magnified 3D plane, so that when we go to do the surgery, we will have a successful outcome, sir. Yes, sir.
Dr. Prasanna, we have just got one project from the government of India.
Yes, sir.
So we are developing this kind of simulator so we can collaborate.
Definitely, sir. Always an inspiration to look up to you in AI and technology, sir. Definitely, sir. Thank you, sir.
Well,
So
Dr.
now-
Prasanna, just ma'am,
Yes,
just
ma'am.
one question. Like, what is your experience for post-ecosporin patients? Suppose you have stopped it for 5 days and after that implantation, any extra? Because Dr. Rashi had a question on bleeding. So, what is your experience on that?
Ma'am, on MIGS procedures, if it's a stenting device like an iStent or an iStent inject.
Well, KDB.
Yes, ma'am. Yeah, I'm coming to that, ma'am. If it's a stenting device, I would be least worried. But if it's a KDB or if it's a bang, I will be moderately worried about IFEMA. And if it's a suture gap, where we are going to do a 360-degree deroofing of the trabecular meshwork. So definitely there will be bleeding that you can anticipate despite stopping the antiplatelets or the ecosprin or something like that, where the bleeding is expected to be part of the procedure, and you will end up with an IFEMA rarely, where it has to be conservatively managed, ma'am. I have had cases in my suture gat patients rather than a KDB or a bang. But in a KDB or a bang, if we are slightly in the wrong plane, sometimes that tends to happen, where the IFEMA has to be managed post-operatively, and it tends to settle, ma'am. Sometimes in one of my routine cases in suture gat, I've had an IFEMA which has taken at least 18, 19 days to settle. But you may end up to add a anti-glaucoma medication in the post-op head and elevation. I've even given ethamsalate tablets to them, and it has taken its time to settle, but you have to anticipate that also in an excisional procedure. Yes.
Very well explained. So I just wanted to highlight that even after stopping the blood thinners also, we can land up in this kind of
Definitely,
scenario.
ma'am. Yes,
Thank
ma'am.
you.
Yeah,
Thank you for that.
Thank you, ma'am. Thank you.
So we should proceed ahead. And now we are taking up retina cases, or all the retina cases are these retina cases which are going to be presented today are Red Buckler Award winners. And it's just like ophthalmic Oscar. So I can see Dr. Vishal Agarwal, Dr. Devesh Kumawat, Dr. Vibhuti Kashyap. So he is a senior Emsonian and he has 2 junior Emsonian for his discussion. So nothing is better than that, and his introduction has already been taken place. So before starting retina presentations, we will like to have discussions introduction by Dr. Rahul Prasad. Over to conference hall.
Thank you, ma'am. Thank you very much. And so far, the evening has been wonderful. We have seen so many wonderful videos now. Now, to introduce the discussant, definitely it's my privilege. And among the first senior members that I'm going to introduce is Dr. Ranjit H. Maniha. Sir actually needs no introduction. He himself is a big name in ophthalmology. Sir has graduated from Lokmanya Tilak Municipal Medical College and Hospital. He has been in private practice since 1982, and his keen interest is in cataract and glaucoma. He has been an ex-PG teacher at Sadguru Netra Chikitsalaya Chitrakoot. He has been a winner of CS Reshmi Award AIOS. He has been awarded the Sadguru Gold Medal and BOA International Master Award. He has represented India at WOC Free Paper Session, Sao Paulo. He is a co-editor of IGO and 2 editorials, organizing secretary of iAdvance Conference since near, and he has got numerous presentations in India and abroad. He has co-authored the constitution of the AIOS and FBS, and he specializes as a system analyst for hospitals to improve services, delivery, efficiency, and cost effectiveness, etc. Our next discussant will be introduced by Dr. Sunil.
So the next discussion is Dr. Ruchi Goyal. The slide, yeah. So she is the Director, Academics and Quality Control, Healing Touch, Super Specialty Eye Care and Visiting Consultant, Rajiv Gandhi Cancer Institute and Research Center. She is ex-Director, Professor, Maulana Azad Medical College, New Delhi. She is the examiner of FRCO London. She is the reviewer of OPRS, Orbit Cornea, IGO, BMJ, Clinical Ophthalmology, and Saudi Journal of Ophthalmology. She has numerous publications like Manual of Oculoplasty, Manual of SSTS with focus on difficult situations and complications, She has to her credit more than 100 index articles in journals, more than 33 book chapters, and 3 CME series by AIOS. She has the academic awards like Dr. B.P. Chadha Memorial University Gold Medals, Srimati Rukmani Gopal Krishnan Memorial Gold Medal from Delhi University, AIOS APAO Honawar Award for Best Paper in the grammar session, AIOS AGO Silver and Outstanding Paper by the International College of Surgeons. So thank you, Dr. Ruchi Goyal, for becoming the discussants. Next will be introduced by Dr. Rahul.
So our next discussant is none other than Dr. Vibhuti Kashyap, young, dynamic retinal surgeon of Jharkhand. And as you can see, he has got so many degrees in his name. I'm quite sure no one exceeds more than him in this particular area in Jharkhand. He has MBBS, PhD, MD from AIMS. He has done his FRCS from Glaxo, USK, FRCS Edinburgh, UK. He has done his FICO Merit, DNB, FICO Retina. He has got a degree of ICO in Retina, ICO in Uvea, and FICO in refractive surgery also. Presently, he is working as a deputy director at Kashyap Eye Memorial Hospital, Ranchi. His area of interest include vitreoretina, uvea. His heart goes to ROP, cataract and retina and refractive surgery. He has done his post-graduation and senior residency in retina and refractive surgery from RP Center for Ophthalmic Sciences, AIMS, New Delhi. And he is an ex-ocular oncology and medical retina fellow from Yugi Sacco Hospital, Milan, Italy, under Professor Giovanni Stogenzi. Currently, he is heading the Department of Retina, Uvea, and ROP services at Kashyap Memorial Eye Hospital, Ranchi.
Thank you. The next is Dr. Devesh Kumawat. He had done MBBS from AIMS New Delhi, MD Ophthalmology from again the Dr. RP Center, AIMS New Delhi, fellowship like FRCO, London, FRCS, FICO, and FICO BIA. He had done senior residency from the same RP Center for Ophthalmic Sciences, and he had worked as assistant professor at AIMS Rishikesh, Lady Hardinge Medical College, New Delhi, and now he is working as an assistant professor at AIMS New Delhi since December 2022. The area specialization of his is vitreoretina, OBA, and ROP. He had over 80 articles published in Index National International peer-reviewed journal, and he is presented as speaker and instructor at various national and international ophthalmic conferences. Next is Dr. Pranita Sahai.
Thank you, Dr. Sunil. Our next discussant is, of course, Dr. Parinita Sahai. She has done her MD from AIMS, New Delhi, MD Ophthalmology from Dr. RP Center, AIMS, New Delhi. Yeah, FRO Opthal from London, FRCS Glaxo, FICO Cornea, FICO, FICO surgery, and he has done a DNB. Presently, she is working as assistant professor, GNAC Maulana Azad Medical College, Delhi. She is also an executive member of Delhi Ophthalmological Society, ex-senior resident AIMS New Delhi, ex-faculty of LHMC, UCMS, CFS New Delhi. She has 88 PubMed indexed publication under her name, has authored 1 book and 27 book chapters. She has also received Best Scientific Paper Award in Keracon 2018 and ISCKRS 2019. And she was a convener at the Surgical Skill Transfer course at AIOC 2023 and 2024. Our next discussant is Dr. Anuradha, and she will be introduced by Dr. Sunil.
Yeah, she is very good name from the Ranchi. She is a cataract and glaucoma surgeon. She has done the MS and FICO fellowship in glaucoma from the University of Toronto, Canada. And also she has done the MBA in hospital management from the BITS Pilani. She is the HOD of Department of Ophthalmology, Bhagwan Mahabir Medica Super Specialty Hospital, Ranchi, Jharkhand, India. And she is the chairperson of the Clinical Audit Committee at Medica Mentor at the Center for Ophthalmic Research and Training, and she is a Doctorate course instructor. Yeah, thank you.
This is the detailed introduction about the all esteemed discussants. So now over to Dr. Vishal Agarwal for his presentation. which is a Red Buckler Award winner presentation. Over to
Thank you,
Dr.
madam.
Vishal Agarwal.
Can you hear?
आपका बहुत अच्छा introduction हो चुका है already.
Thank you so much for the kind words,
And
madam.
he's chairman scientific committee also for Rajasthan state.
Can you hear me, madam?
Yes, yes.
Yes. So thank you, Jharkhand Ophthalmological Society, for having me here. And good evening to all the seniors and the colleagues who have logged in. And a special thanks to Vibhuti madam. Her dynamic and vibrant personality always impresses me. So I just thought that the academics have been, have made the session a little more serious. So this is just a fun video which we presented in Seattle, and it won the Red Buckler and has won many other awards, including the Image of the Year award. It's just a a musical video with subtitles and a voiceover. It's actually self-explanatory, so it does not have any voiceover. Can you hear the audio?
No, doctor, the audio is not coming. Can you just pause this presentation?
I paused it from my side.
Yeah,
Is it still playing?
No, just give me a second. There is a floating bar, right? There are 3 dots.
Yeah.
Just click on that. You will have an option called share sound. Share computer sound. Just check that box.
1 second.
Now you can resume it. We should be able to hear the voice.
Where is the floating? 1 second. Yeah.
Next to stop share, there is a
share computer sound, right?
Yes, perfect. You can resume from the start.
I'll just check whether.
I present to you the eggs!
Is the sound audible now? Yeah, can you hear the video?
Eggs!
Can you hear the video sound now?
Yes.
Yes.
Okay. Okay, now I'm playing it. Thank you.
A little softer also.
And my father's father and my weird Aunt Chloe have all searched for the eggs, but only I, King Mudbeard, have found them. I present to you the eggs!
Whoa, what did I miss? You gotta fly those eggs to safety.
I got this. Here we go!
Yes!
now for our last gift to you.
Shut up and fix my house!
Out of here.
Thank you.
That was lovely, Vishal. That was really lovely.
Fantastic, fantastic.
So over
Thank
to
you, sir.
the VR surgeons, Dr. Vibhuti and Dr. Devesh.
Hi, Devesh. Hi, Vibhuti.
How are you? Hi, sir.
Good, good.
How are you? Sir, of course, the Americans have already said it's a fantastic video, probably the best video of the session. That's why you won it. Everything was by the book. I just had one small query.
Yeah.
What made you remove the cyst from the past when a rodent? Why not eat it up inside? I mean, we don't essentially need to
Yeah.
take it out.
Yeah,
Why
that
was
was
that?
yeah, we don't do that. I totally agree, and that was a very, that video, that image won the image of the year 2019 also. And I was just, curious, and just for the editing part, I just took it out. You could have eaten it inside also, just for the sake of recording and documentation. I took it out. Otherwise, you're right. In all other cases, I have eaten the cyst inside the vitreous cavity.
And so secondly, just in the last case in the submacular cyst, um, so don't you think that the retinotomy should have been slightly away, because the place at which you made the retinotomy, a slight inadvertence, and it may have as well burnt the cyst wall, causing a subretinal leak.
Okay, so there are 2 points. The site of retinotomy was at the edge of the the bleb and the attached retina. So if I would have made it more peripheral, I would have we would have the risk of damaging the choroid, and it could have led to a bleed. Okay, and the second thing, but the burning of the retina, it was a very mild burn on the superficial bleb, the retina. There is always a chance of burning the cyst wall. You are right, but I think it was very safe. And the only point I want to make here is that it should be a very small retinotomy, because the cyst has amoeboid movements, so you don't need to just squeeze it out according to its size. It adapts to the retinotomy size and comes out very easily. But I would not have made the retinotomy on attached retina. It was at the border of the attached retina and the neurosensory detachment.
And so lastly, what would you do if, say, the cyst wall ruptures subretinal?
Nothing. It's a infusion based system. There are the traditional teaching which we were taught when we were doing MD was that there are a lot of toxins released and you have to remove it in toto outside the vitreous cavity. We now know that the continuous fluid infusion, whether it's subretinal, it's it ruptures, or it is in the vitreous cavity, it does not cause any reaction in the post-op period. So it's not a concern to me at all. The cyst which we removed was purely for academic reasons. It was not scientifically rational to. It is not scientifically rational to remove it. You can eat it inside the vitreous cavity.
A wonderful bouquet of surgical videos, sir. Always a treat to watch your videos. So, although Dr. Vibhuti has already mentioned, so I think only one situation that is left over here that you could have also shown is external removal. I don't think you do it now, or it has become very obsolete. Maybe from your senior residency or that duration, you can have a video in which you have removed. Have you removed them externally through the sclerotomy?
No, I don't. And when you mentioned that, in hindsight, I would like to have removed the one I showed you, which was, a band-shaped cyst. near the pars plana, very in the nasal periphery. That could have been approached in an external manner, but we did not know what we were looking for when we went inside. It was surprised that it was a cyst because the USG also did not document that. So that cyst could have been approached in an external manner. You were right.
And is your treatment approach any different when you don't have any retinal detachment? So we have cases in which you don't have retinal detachment in the area of the macula, and there is a submacular cyst, hardly any retinal detachment or neurosensory detachment. So do you think a 41 gauge needle you can use it outside the macular area to induce a neurosensory detachment and then maybe expel the cyst?
Yes, definitely. I have one video for that also, where there was a submacular cyst and the exudation was not that large. So I used a 42 gauge cannula to inject fluid subretinally, and that made the surgery easy. You were right. We can use that approach also. But in this case, of course, there was a huge bleb, so it came out easily without the injection of subretinal fluid.
Nice video, sir. Thank you, sir.
Thank you so much.
Great presentation, Dr. Vishal, and self-explanatory. That I really liked. Thank you.
Sir, pranam, sir.
And Dr. Vishal, please stay with us as a discussant, because the next case which we are taking, that is a subfoveal cysticercosis by Dr. Veer Singh, and it's continuing the legacy of Dr. Suhan Singh from Amritsar.
Sure, madam. Sure.
Very big hospital there.
Yes.
So over to Veer Singh, and for this,
can you hear me? Am I audible?
Yes, you have three discussants: Dr. Vishal, Dr. Vibhuti, and Dr. Devesh.
Thank you for the warm welcome, ma'am, and the opportunity to present at this forum. I'll just share my screen. So just go with that. Yeah, so I think my screen is visible.
Yes, it is visible.
Yes, kindly let me know if the audio is. Thank you, SRS, for giving me the opportunity to showcase my film at the annual con. So is the audio there?
Yes.
Okay, so I'll just go ahead. Yeah. So this is a presentation that won a Red Buckler at the 2023 Seattle ASRS conference in Seattle this year. I shall be presenting a case of subfoveal cysticercosis, aptly titled "The Curse of the White Pearl." A 34-year-old female patient presented with diminution of vision in the right eye since 5 days. Best corrected visual acuity in the right eye was 1 meter and in the left eye was 20/20. The anterior segment exam was unremarkable in both eyes. On fundus exam, there was a live subfoveal cysticercus cyst or the cursed white pearl, which showed movement on subsequent fundus photos. On OCT, the cyst was lying bang under the fovea in the subretinal space, creating a small neurosensory detachment. After neuroclearance, surgical removal of the cyst was planned. The surgical plan was to use a 41 gauge cannula to inject subretinal BSS and create a macular detachment. This is followed by PFCL injection to displace the cyst temporally and finally extract the cyst through a temporal retinotomy, saving the fovea. Now let's see how the surgery really went. Notice the subtle movement of the cyst on shining the light towards it. After core vitrectomy, triamcinolone assisted PVD induction was attempted using the cutter. Since there wasn't much vitreous to hold on to, it was extremely difficult to get a good grasp of the posterior hyaloid even on high suction. After multiple failed attempts, due to the extremely skytic, thin and strongly adherent nature of the posterior hyaloid, ilim forceps were used to initiate the PVD near the optic disc. The cutter was then used to complete the PVD and finish off the vitrectomy. The peripheral retina was then examined and no peripheral lesion was found. The focus was now shifted towards the cyst at the macula. Brilliant blue G was used to stain the ilim and ilim peeling was done. In an attempt to reduce the amount of post-operative macular drag that may result from a temporal extraction retinotomy, a large arcade-to-arcade ilim peel was done. Meanwhile, a 41 gauge cannula attached to an automated microdose injector was prepped with balanced salt solution. Keeping an injection pressure of 6 millimeters of mercury, a macular detachment was created by injecting BSS in the subretinal space at a reasonable distance from the fovea. Notice the controlled, slow and steady elevation of the fovea and the cyst. Multiple site BSS injection was done to increase the size of the macular detachment. The aim was to have a large enough detachment so that an extraction retinotomy
can be made as far as possible from the fovea. But the cursed pearl had other plans, and then the unexpected happened. While injecting subretinal BSS, the cyst just popped out of the fovea like an explosive volcanic eruption, and all my surgical planning went into the trash. Let's watch that again in slow motion. After a careful analysis of the cyst, I slowly approach the retina, and as I inject BSS into the inferior bleb, the fovea gives way and the cyst erupts out into the vitreous cavity, forming a tiny macular hole. The cyst then casually sinks down and lands on the optic disc. I then use the cutter to eat up the cyst. I slowly approach the cyst on cutting mode, and zoop, it went into the cutter's mouth. Since the iatrogenic macular hole seemed very small in size and the ILM had already been peeled, I was quite certain and confident that the macular hole will close. Air fluid exchange was done, 20% SF6 gas tamponade was given, followed by prone positioning for a week. At 1 month post-op, to my utter surprise, the best corrected visual acuity had only improved to 20/200. On OCT, the macular hole persisted, and thus the curse of the white pearl had not been lifted. It was only after the first surgery I learned that I needed macular massage and an ILM graft to lift the curse. After learning the remedy and a detailed discussion with the patient, I took her up for a second surgery to close the macular hole and lift the curse. The second surgery, since the ILM was already peeled, a silicone-tipped diamond-dusted Thanos scraper was used to do gentle macular massage near the superior, inferior, and temporal edges of the macular hole. The papillomacular bundle and the nasal edge of the hole were not touched at all. In the absence of ILM, this maneuver significantly reduces the size of the macular hole and greatly increases the chances of hole closure. Some more macular massage was done a little further away from the hole margins to loosen this retina as well. The silicone tip of a backflash cannula was then used to passively drain and oppose the edges of the hole by gently touching the edges just a few times. Additionally, an ILM graft was harvested from the edge of the previous peel, and a PFCL bubble was injected over it to stabilize the graft. Under PFCL, slowly and carefully, the ILM graft was then moved and positioned over the macular hole. After proper placement of the ILM graft over the macular hole, a slow air fluid exchange was done. To reduce the chances of any graft movement or graft loss, it is important that the air fluid exchange is done slowly. Another important measure is to keep the soft tip cannula away from the graft, preferably around the nasal margin of the disc towards the end of air fluid exchange. After removing all the fluid from the disc, the macula was dried as much as possible, making sure that the ILM graft stayed in place. 14% C3A-FIT gas tamponade was used, followed by 1 week of prone positioning. 1 month after second surgery, the best corrected vision had improved to 20/120. The OCT showed a closed macular hole and the outer retinal layer integrity was disrupted. At 2 months, the vision had improved to 20/80. The macular hole was closed on OCT and the outer retinal integrity showed some improvement. And at 3 months, the best corrected visual acuity had improved to 20/60. The macular hole was closed on OCT and the outer retinal layer integrity showed significant restoration with a small central defect left in the ellipsoid zone. To summarize, the patient went from having a subfoveal cysticercus cyst to developing an iatrogenic macular hole and eventually had the macular hole closed. She had a good final visual outcome as the vision improved from counting fingers at 1 meter on presentation to 20/60 after the second surgery. At last, the surgeon and his team emerged victorious and the curse of the white pearl was finally lifted from the patient. Thank you.
Sat Sri Akal, Veerji.
Hi, sir. How are you?
Always great. So can we use this autologous retinal transplant or this anterior capsule flap also for these macular holes?
So people do use a lot of ARTs these days, autologous retinal grafts. Personally, I'm not in favor of those for this size holes, and especially when I can easily use a free flap or do a macular massage. So I think everybody has their own take. For larger holes, yes, an auto retinal graft could be useful here. But I usually try to close them up with the ILM per se. Yeah.
Most traditional one. Great video. Congratulations on winning the award.
Thank you, sir.
Wonderful video, Veer.
So-
So one observation that I made was that you made an ILM peel
Yeah,
your primary surgery.
बोलो कि मैडम हम लोग
For I
का कॉर्निया केस ले रहे हैं.
subretinal injection, or I've seen others also. So it is always better that you don't peel it in the first sitting, because a macular hole may form later on when you are injecting the fluid. Although you had injected with the injector, or even then the macular hole had developed. So it is always better that you keep the ILM as a backup in case the macular hole develops, and you can put a flap in the primary surgery itself if it develops. So that was the observation that I wanted to make. Rest, the videos were very wonderful, and it was great you won this award. Thank you.
Veer, excellent video and excellent management of a complication. And the only thing I would like to add in extension of Vibhuti's comment is that what you do with the ILM flap under PFCL is very tricky, and it can easily dislodge when you aspirate the PFCL. And it was almost dislodged in the last frame of your video, but you still managed to keep it in place. So if you're doing a massage, you're already opposing the edges, and there is very little space for the flap to be inside that hole. So when you are planning for an ILM flap, you could have done that and avoided the massage, because that would have caused a little less RPE trauma. Or if you have done the massage, I think it was almost opposed at the end of the massage, and no ILM flap was needed. So that is my 2 cents for this. Otherwise, great surgery, great video. Congratulations.
Absolutely agree with your comments, sir. So I am more of I prefer to do the macular massage. I think it has a very good closure rate. So keeping a flap over it. Also, I am not in favor of stuffing the ILM inside a hole. So the idea was, since the patient was a young patient, it was a second surgery. So it was just like a extra blanket of safety. That's all. That's all. It might not even stayed there actually.
किसके पास?
Yes.
Dr. Veer, very nice video. Just my 2 cents to it would be like, since as Vishal sir already mentioned that by massage it was almost already closed. The other thing that comes to my mind, apart from, of course, a flawless surgery of yours, is that we could have probably used a subretinal infusion, subretinal injection just around the hole to cause an apposition of an already almost opposed macula, but hole edges. But I mean, your technique was equally effective. I'm just talking about an alternative that.
I would do that in a very chronic sort of a hole, where say it's like that sort of a type 1 hole, in which there's a lot of say there's no mobility in the retina. So this is a rather very fresh. I understand what you're talking about, injecting subretinal fluid and then doing fluid exchange to loosen up the edges, but I don't think it was required here.
I mean, it's just about can there be an alternative? This may have been an alternative, but whatever you have done is worked perfectly well.
Please comment about the ILM peel. So maybe in the back of my head, I already thought that it might have a blowout macular hole. So that was, in fact, I usually don't peel the ILM, but that was in anticipation for if at all a macular hole occurred. And I was anyway anticipating that the hole would be very small. So I would have done a conventional peel anyway. So I just peeled it before going for the. But to my surprise, the macular hole stayed open. So that was the main thing here. It should have closed such a tiny hole, even with a conventional peel.
If all scientific discussion is done, I'd like to ask him, what was the expression when the cyst came out through the hole? Did you say, oops? Or did you say, dhat tere ke? Did you say, wow? What did you say? What was the expression?
So that's an interesting take on it. In fact, my entire OT staff, my sisters, everybody was glued to the monitor, to the TV screen. And I didn't say anything. There was a synchronous sound in the OT of all my staff saying, whoa, like that. So, and I looked up and I was like, where did that come from? So I was just looking at my OT staff.
Yeah, something tremendous,
Once in a lifetime, probably. Good, good.
So, thank you, Dr. Veer. So, 2 consecutive presentations, both the presentations were winner of Red Buckler, and both the presentations had cysticercosis management. So many things common.
True.
So, thank you, the retina discussants. So, remain there on board. We are going to invite Dr. Bharat Gurnani, and the discussant is Dr. Pranita Sahai. After this, we will take up Dr. Subhav. His case is very interesting, and Dr. Maniyar sir can discuss on this. Dr. BP Kashyap sir, Dr. Maniyar sir can discuss with Dr. Subhav.
मैं सर कब से हो गया तुम्हारे लिए यार?
भरत का ही तो कर रहा है. No, Dr. Bharat.
Yes, ma'am. Ma'am, I'm audible, ma'am.
Yes, yes.
Thank you, Bharti Kashyap, ma'am, Vibhuti Kashyap, sir, and Maurya, sir, for this opportunity. I'm really feel privileged and honored to present here, and
अरे
really.
मौर्य सर नहीं, this is the SK Mitra, the secretary, the president.
Ma'am, yes, ma'am, for the recommendation from the Maurya, sir,
Okay.
Bharti Kashyap, madam, and Vibhuti Kashyap, sir. Thank you, sir, everyone, and thank you, Jharkhand Ophthalmic Society, for this honor. And I'll share my video, ma'am.
AI in corneal disease.
Is it audible, ma'am?
Yes, it's audible.
Refractive errors and corneal diseases are the primary global causes of blindness. AI is reshaping patient care, making it more accurate and personalized. Let's explore the era of AI in corneal disorders and refractive surgery. The demand for perfect vision is increasing the number of cornea or lens-based refractive surgeries. With advancements in AI technologies, researchers and clinicians are now focusing on the less explored areas related to the eye's anterior segment. Slit lamp photography, anterior segment optical coherence tomography, corneal tomography, in vivo confocal microscopy, and optical biometers are frequently used to study various corneal conditions. These conditions encompass infectious keratitis, keratoconus, corneal grafts, ocular surface issues, pre-surgery evaluations for vision correction, calculations for intraocular lenses, and automated refraction. Before embarking onto the disorders, let's understand a few basic principles of artificial intelligence. AI is engineered to emulate human actions and make decisions reminiscent of human judgment through sophisticated coding. In recent times, the popularity of machine learning techniques has surged. These ML methods use sample training data to create models, such as logistic regression, artificial neural networks, and decision trees, allowing them to make predictions or decisions without specific programming. Deep learning is a specialized branch of machine learning that has proven to excel in various domains. By autonomously identifying hierarchical features, DL algorithms enable intricate relationships between input data and decision-making outcomes. The foundational concept of the convolutional neural network, coupled with a significant technological advancement enabling the training of deeper neural networks, deep CNNs, have set new standards in numerous image-related tasks such as object recognition, image segmentation, and disease classification. Model training is deeply influenced by the caliber of the training dataset. Especially in medical contexts, clinicians often enhance the data quality by offering detailed annotations, whether they're at the pixel or image level, or even a combination of both. AI has effectively been applied to predict diagnoses for a range of corneal disorders, such as infectious keratitis, keratoconus, pterygium, endothelial conditions, and complications related to corneal grafts. Detecting early stages of form fruste keratoconus or potential keratoconus, particularly prior to refractive surgeries, continues to pose a clinical hurdle. AI has demonstrated its efficacy in identifying corneal ectasia, including keratoconus. AI-powered tools have enabled us to remotely monitor patients, thus augmenting their care and minimizing hospital visits. October images have been utilized to distinguish between normal corneas and edematous corneas using algorithms based on deep learning techniques. There has been an increased clinical interest in the use of in vivo confocal microscopic images to analyze subbasal nerve plexus features and correlate them with ocular and systemic diseases. Utilizing deep learning algorithms for the complete automation of analyzing corneal endothelium parameters through specular microscopy in eyes that have received ultra-thin Decimé stripping automated endothelial keratoplasty, DSAKE. AI-assisted analysis of data obtained from Scheimpflug imaging has been shown to predict the need for penetrating and lamellar keratoplasty. Artificial intelligence in refractive surgery. The use of AI in screening prior to refractive surgeries is crucial for identifying individuals at a high risk of iatrogenic ectasia. This is achieved through the utilization of the Pentacam Random Forest Index, PRFI, a machine learning algorithm trained on random forest, RF, data. AI has been utilized to suggest suitable refractive surgery procedures and the accompanying nomograms. Deep learning has been employed to predict refractive errors using imaging analysis, such as fundus images. The Visual Behavior Monitor is an innovative wearable device designed to accurately assess the visual behaviors of patients before surgery. This information helps determine the best course of action for refractive correction interventions. The monitor used machine learning algorithms to evaluate data sent to the cloud and analyze patterns in lifestyle, such as the type of lighting used, reading distances, how long reading or other tasks were done. Adhering to research, governmental regulations, and predicting future trends will be crucial for realizing AI's full potential in ophthalmology. There has been a paradigm shift, where technology and medicine converge to foster a future where eye care becomes more precise and accessible. It's a comprehensive guide for professionals eager to understand and harness the power of AI. Hence, the integration of artificial intelligence in managing corneal and refractive disorders is reshaping patient care, making it more accurate and personalized. The acknowledgement of the worldwide impact of corneal diseases and refractive issues has brought attention to the lack of sufficient screening for these conditions, particularly in countries with limited resources. With advancements in anterior segment disease, it is probable that both imaging and non-imaging based AI algorithms could facilitate prompt diagnosis and treatment of corneal diseases, as well as progress in refractive surgery. With deep learning models, we've been able to diagnose conditions with unprecedented accuracy, reducing human errors significantly. By leveraging AI analysis, we have been able to tailor procedures to individual needs, ensuring more predictable and efficient results. Eye's ability to predict corneal complications and streamline refractive care is enhancing recovery paths. By now, we can say that the tangible benefits of AI integration in corneal disorders are beyond words. With AI integration, accuracy is enhanced, personalized plans are facilitated, and patient care is augmented. The research, case studies, and first-hand insights underscore AI's positive impact, but we must also be mindful of ethical considerations and potential limitations. Automated diagnosis is transforming the way we identify intricate corneal patterns and refractive anomalies, and in future will facilitate diagnosis and treatment armamentarium of clinicians.
Excellent award-winning video, this Dr. Bharat, and it's untouched part because mostly these applications, they are on this IOL marking, toric, or the cataract, or the posterior segment mainly. So you touch this aspect, it's really well. So what are the, why there are so many biases and confounding factors when we are talking about AI applications dealing with the cornea, and how to overcome these factors?
Sir, if we go as per se, if we go per se the literature review, if you see when I was making this video, The idea was to study like how AI has been used in cornea and refractive disorder. So if you go into the literature, there are a lot of studies with wide variety of applications, but there is no such application or no such single user interface you can use to predict. Because I wanted to do a study where I can have my own data set and I can predict something like a microbial keratitis, or whether it's a pythium, or whether it's a fungus. So there has been a lot of variability, and there has been a lot of still there is a lot of development going on these softwares and deep learning algorithm. And another thing is, due to the varied the anatomy and presentation of cornea, probably if you see glaucoma, if you see retina and all, it's well documented AI. But still in cornea, there is like still there is a it's still under the evolutionary stage. So that's why the reason is like there are a lot of confounding and the results are not up to the expectations, and maybe the sensitivity and specificity of these softwares and the apps is not that accurate. So that was the whole idea of preparing. And there was a like there is a special section where you can submit in AI videos in APO. So my target was that. So, and we published this paper also in French Journal of Ophthalmology. So
All
that
the
was
very
the whole
best.
idea
All the
of
very best.
get more information, and how we can utilize this AI detection softwares or algorithms or apps to maybe do a study from a lab, or maybe having our own data set of 5-7 years, and may predict keratitis or a keratoconus where adequate facilities or lab facilities are not available.
So is it because of the lack of the normative database
Yeah,
of
probably.
different countries?
Yeah, and if you see, there is a lot of heterogeneity in the, like a keratoconus in India may not be the same in US or maybe in UK. There is a variability of presentation. You may find a fleecious ring in a keratoconus in US, but may not be in India in some regions. So because of that, the heterogeneity of data, so there is a lot of lack of validity in a good normative database compared to a fundus image or a glaucoma presentation, which is a straightforward presentation, probably a cotton wool spot or a dot and blot hemorrhage, like that.
More importantly, I think for glaucoma and cataract, to develop an AI-based software is more easy because the database itself is huge. For corneal patients, the corneal ulcer patients, to you baseline data of at least thousands and thousands of patients is required to develop these AI software. To have those thousands and thousands of ulcer patients with a definite proven diagnosis that you can feed into these softwares and then establish prediction, that is something very challenging because we don't have that established database as of now. But as of now, even RP Center, Dr. Radhika Tandon ma'am, Professor Radhika Tandon ma'am is currently doing a study wherein an AI-based prediction of corneal diseases. She's doing it in collaboration with IIT Delhi, as far as I know. So I think maybe in a couple of years, we may have something, definite even from our own country for corneal disease prediction based on clinical photography.
Dr. Bharat, one question. We're looking at numbers here.
Yes, sir. Good evening, sir.
In the initial machine learning, how many cases were fed to the neural network, to the agent, artificial agent, AI agent?
Yes, sir. Like if we see other studies, sir, they have normative data of 7,000 to 10,000 images, which, as Pranita madam said, may not be available to every cornea specialist or a setup where we are doing a study. So that is a challenge still ahead. And because I have a lot of good images with me, so I thought like, can I do something with these images, and can I predict one keratitis which I am not able to confirm laboratory wise, or I'm not able to predict prognosis of this case? Sometimes you think like, yeah.
Essentially, where machine learning is concerned,
Yes,
we
sir.
have to have the numbers. So
True.
maybe a collaborative effort through any of your cornea societies all over Singapore, National, Australia, UK, Europe, etc., may be a right way to go ahead, because their numbers come with collaboration. Numbers will not come with a single individual.
True, sir.
So the ML part is with numbers. Then the convoluted neural network part will again need very substantial numbers to validate that. And then you will have to cross-check that with clinicians
Correct, sir.
all across the globe to be able to validate the algorithm that you are, proposing. So that's the way to go. I'm glad you made the attempt, but it's really incomplete at this point. It's incomplete.
Sir, like I was looking for, is there any app or something validated software available where I can like try and predict? So the idea stems from that, and secondly, it also involves the effort of like scientific by engineering part and all to develop that algorithm and to develop that app, because it may not be possible for us. We have the data, but to scientifically give it that shape, we need some expert inputs also from people who are high tech or like from the engineering background. Bro.
That is the role of the computer vision.
Yes, sir.
AI, computer vision AI, where similar images are fed to the agent and then it learns. In deep learning, it's the other way around. The machine is fed the images and then it diagnoses on its own. Whereas in ML, you tell the agent that this is keratoconus.
Agree with you, Ranjit sir. And there is a good news for you, Dr. Bharat. So we have just submitted a project on cornea or AI. So the Ministry of Information and Technology, along with the NILET, so we will be having a full team of NILET Director Kohima. So a lot of engineers will be there. So whomsoever are interested in this multicentric study on cornea AI base, and they are most welcome.
In fact,
happy to collaborate.
Dr. Maurya,
yes, sir.
Just gone through a paper where you have a retinopheno age that helps to predict life outcomes, mortality, morbidity also.
Yes, sir. It's proven, sir.
And it's amazing. I mean, it's going to put a lot of cardiologists and urologists, etc., into disrepute.
Absolutely, sir. So technical committee, they have finalized it. Now it is with the finance.
Great news, great news.
Yes.
Now, we go ahead.
Thank you, sir, for your kind wishes.
Thank you, sir.
Thank you. So again, another multiple time Merit Buckler Award winner, Dr. Srinivas Joshi is on board. She has won the Red Buckler Award for 5 times. So welcome, Dr. Srinivas Joshi. Hello.
Thank you, madam. Thank you, Bharti
And
madam.
retina discussant, Dr. Devesh Kumawat, Dr. Vibhuti, are you here?
Yes, ma'am.
This is Devesh.
This is Vibhuti.
Okay, please call Devesh also. So because we are starting the presentation by Dr. Srinivas. So, okay, over to Dr. Srinivas.
Yeah, thank you, Bharti madam and the entire Jharkhand Ophthalmic Society team for hosting this very interesting webinar. So, since I'm traveling, so on my behalf, my colleague Dr. Subhav Prasad will be playing the video. So this video was won the Red Buckler Award in 2020 during the COVID year. So I'll be showing how to deal with the pediatric retinal detachments, especially with the closed funnel RDs. So these were all the pediatric retinal detachments, and I'll be showing it one by one. We have a subtitles also, it's self-explanatory. Wherever it's required, I'll just try to pitch in. Request Shubhav to please start the video.
Done, sir.
So we all know that the pediatric RDs are known to be difficult with high chances of redetachments. On top of that, if we have closed funnel RD facing us, then definitely we are in deep trouble. So it's very easy to give up at that point. But when we say that, let's us try for these tiny little eyes, I think a persistent presenting a series of such challenging closed funnel RDs. Can we have the sound, Subhav?
I think you need to have the sound sharing in this.
Okay. Shubhav, can you just stop it and do the sound sharing?
In a minute. Sunilji, can you just help me in guiding him with that?
Please replay that video. Please replay.
Yeah, I will.
Mr. Sunil, can you please help us in getting the audio done for that? While sharing, you have to press that button as share sound as well, Shubhav. You can stop the share.
Subhav, stop sharing, close it, and then again reshare. Then there will be that audio sharing option.
Sure, sir.
Hi, Joshi. So good to see you.
Yes, boss. Nice to see you too. Sorry, I'm traveling on the road, so I couldn't be
Best
there.
of journey.
Yeah, thank you.
This is an inspiration. This is an inspiration for all of us, because whenever you call somebody, that person will say, I'm traveling. But you are traveling, still you are attending, and you found a way, and you contacted your friends to play for you.
Yes, madam. Thank you.
Hats
Thank you
off
so
to
much.
you.
Hi, Srinivas.
Hello, sir.
Yes. How are you? Fine.
Yeah, fine, sir. Good evening.
Okay.
This is how you
Subhav,
honor your
what-
commitments.
Yeah,
Yes,
Subhav,
sir.
what happened?
1 minute, sir. Just playing it. Is it audible, sir?
No, the audio is not.
No, not yet.
Dr. Subhav, can you
Go little
make up the
forward.
audio?
Yeah.
Yeah. Thank you.
Can make it full screen, Subhav.
Just don't know when to give up, do you?
I could do this all day.
So actually, these were the very bad membranes. And finally, after injecting the PFCL, we could see the retina settling.
Oh God, his car's so blistering. In these conditions, it must be almost impossible to drive a car.
So this was another case of traumatic closed funnel RD. The primary corneal tape repair was done, but when the patient was referred here, it was looking like an Eiffel Tower. subretinal membranes were removed meticulously. The subretinal blood clots were also removed. Finally, with few codes, we could see the retina at least settling well. Lasering the edges. And this is the last case.
Don't ever let somebody tell you you can't do something. You got a dream, you got to protect it. You want something, go get it. Period.
So this was another story of an unfortunate kid who got hit twice, once with a football and once with a tennis ball within a span of 15 days. So lensectomy was done. On was used post-funnel RD again. Now slowly trying to open the funnel. Finally, I could, with a lot of stretching, I could release these attachments slowly, and then step by step I started injecting PFCL to settle the posterior pole first. Again, I could see the lot of membranes, so I had to remove the PFCL and remove the blood clots, the fibrotic bands. Incremental retinectomy was done step by step. And slowly, step by step, PFCL was being injected to flatten it. But temporarily, I could see a lot of traction still persisting. So I went ahead, checked if there were again few membranes coded. So this was a very small zone. But finally, I could see a settled retina up to the mid-equator area. Now lasering the edges with a fluid exchange. And silicone oil was injected. I feel that's the happiness in the VR surgeon's life. Though couldn't give 6.5 vision to this child, but definitely giving some ambulatory vision also at this stage. I think the VR surgeons will be really very happy if we can be of some use to those small, tiny child.
Lovely.
Thank you very much.
Thank you. Those were the 3 P's, I think. That was PFCL, persistence, patience, coupled with a hell of a lot of skill. Lovely.
Thank you, sir. Thank you so much.
Congratulations, sir. You proved yourself to be the Will Smith of ophthalmology.
No, nothing like that.
Sir, I have 3 questions for you in pediatric retina. First, sir, do you fathom the use of a buckle support in such VRs?
Good question, Dr. Bibhuti. But since this was already a 360, already retinectomy was done. If there was only inferior retina attached in the beginning, then I would have definitely made it to add a buckle. But since this was
so the first case that you operated, it was not 360. It was just a closed funnel which you were trying to dissect. The first case.
Yeah. So in that first case, since I already had to do a retinectomy because there was a lot of anterior PVR, which was not allowing me to settle. I did try with the fluid air exchange, but until I removed the anterior PVR completely, the retina was not being able to settle. Good question is because if the retina would have been settled, then I would have definitely placed a buckle as an extra precaution, especially the inferiorly. But since in that first case, since the retina was not being able to settle with the 360 retinectomy, so I thought adding buckle will not be of much use.
And so secondly, what's your view on ILM peeling in such cases to remove the nidus of a posterior pole pucker in cases of retinectomy with a heavy barrage, especially in kids? Because I face this as a lot, and to combat this, what I've started using is I have started to do ILM peeling in such cases. Although the results are pretty disappointing most of the times because of the pediatric nature and the closed funnel RD or the narrow funnel RD situations. But do you think that spending time in ILM peeling helps?
Again, very relevant and pertinent question. As you know, Dr. Bibhuti, you were also there in the Stockholm in the ASRS where they showed that doing of ILM peeling has not shown to be beneficial in the recurrences of the PVR. However, some authors are of the opinion that in very bad PVRs, doing an ILM peel might help. But since we don't have a control between the non-ILM peel and the ILM peeling cases in such grade D PVRs, so it is very difficult to arrive at one point. Rather, peeling of ILM, of course, would have added extra benefit to these kids. I would rather suggest to go in for methotrexate, IV methotrexate, intravitreal methotrexate of 0.4 milligram in around 0.1 ml. You also know about the GARD trial, which has shown that it has shown to be little beneficial. Especially, they have shown around the 78 to 90% of reattachment even after removing the SORs. So, you know, the PVR is the biggest culprit in these kind of cases, especially in the pediatric RDs. If we get any a mantra or the agent which tries to not give this PVR at all, I think that is when a vitreoretinal surgeon will achieve the biggest success in their lives.
True that, sir.
Wonderful surgery, sir. So I
Thank you,
have
Devesh.
questions related to the post-operative management, sir. So what? So you routinely use methotrexate in such cases during the intraoperative period?
No, Devesh, I always use intravitreal dexamethasone as of now because I was waiting for the methotrexate trials to come out and see how safe and effective it is. The only problem with these is even IV dexamethasone also is short acting. Methotrexate is also short acting,
Yes,
and
sir.
most of these trials have shown that they have to give at least 5 injections in a year. So every time put this child under general anesthesia, under oil, keep injecting is a little cumbersome. So I'm just waiting for a solid proof benefit. If we get to know that intravitreal methotrexate definitely has a proven benefit, then I think it's worth trying. Although we might have to induce the child under sedation or general anesthesia at least once in a month or once in 6 weeks. But if the eye is going to stay, I think it is still worth it. But I have given only in one case, and I'm just waiting for to see how it performs.
So do you try short-term PFCL tamponade in such eyes so as to iron out the retina further and then take up the child for secondary?
Definitely, I would have definitely done that if it was an adult case, not in the child, because child will keep moving, and I feel that more of turbulence, like if they keep shaking their head, they rub their eyes, and all those things, that is still more dangerous and deleterious. And I feel that PFCL will go underneath the retina, even if the retina is attached. Sometimes these disturbance, these causes the small tiny bubbles of the PFCL, which might be still more worrisome. But if it was an adult, yes, definitely leaving the short-term PFO tamponade in 2014 as first described by Steve Charles, it makes sense.
So how has been the long-term outcome of these patients after SO?
Very good question. I was waiting if anybody would ask that. Devesh, in these three eyes, to be very frank with you, two of the kids still are maintaining, but one kid has a very severe hypotony. He is now, I think, under 4 or 5 millimeters of mercury. But the only thing what I see is that eye has not gone into phthisis. It is just still doing there. And I somehow feel that doing such cases in the long term, they do develop hypotony.
Yes, sir. And to the surprise, I have noted that the emulsification on the contrary, it is not that frequently
Bad.
happening in the eyes, and you do not need to exchange the oil frequently in these eyes.
Exactly.
For
Exactly.
2 years or 3 years down the line, the patient will come, you'll have a bad redetachment also maybe under oil, but there won't be any emulsification of oil.
Yeah, especially in the children. Very interesting to note that point. Even I have noted that. In adults, definitely it emulsifies, but in such instance, what I do is in the primary instance, sometimes I start in the Micromed company. I put the 5,000 centistokes silicone oil or the dark 5,000 centistokes silicone oil, which I have not seen much of emulsification happening with these two oil companies, what I have used.
Thank you, sir.
Hi, sir. Can I make a comment?
Yeah. Yes, Veer.
How are you,
Of
sir?
course. I'm good.
Nice
How are you?
presentation as always.
Yes, thank you, Veer.
So it's a slightly a different question. So my question is that, so you've, of course, these amazing cases that you've done. What's your threshold? Say, I mean, if a child, would you regularly do these kind of severe detachments in children when the other eye, say, has a 6/6 vision, or is that a regular thing that you do, or maybe you will
No,
just,
no.
what's your
Veer,
threshold for saying that that's left alone? And
earlier,
also, of
earlier,
course, if it's a one eye
earlier,
status, we would, so that's something.
no, earlier I had full Josh like you, Veer. So I wanted to try that. But off late, when I'm seeing my own cases that they are going for hypotony, and if the patients are also not keen, I usually don't enforce them to go for that. These are the set of cases where the parents wanted to do something. They were like, you try, sir, let us see what happens. Let's leave it to the God. Please give a try. And that is when I thought I should give a sincere effort, is because the parents are requesting me. If the parents is, because most of the time, these very good pertinent question you have asked, because all the time they ask for guarantee. Most of these parents or adults are asked for guarantee. When they utter a word called guarantee, that is when I don't touch that
That's
child at all. That is when I know that these are troublesome. But if the
I'm
patients are,
following your footsteps now. You, like you said earlier, in our earlier days, we are in a lot of Josh. We do all kinds of cases. Eventually, we kind of realize that which
yeah,
ones to
once
touch
you
and
have
which ones
your own
not
set
to.
of cases, then you will get to know which
True.
case to touch, which case not to touch, and how are the parents or how are the this thing, because it's all they have to bring the child each and every time, and so it is a burden for the parents, not just the children. So I think that is where we decide on
I think it's important
Excellent.
that this question was important.
that. Very
Excellent
good.
Thank you, sir.
surgical management of this closed funnel pediatric RDs. It was like opening a Pandora box layer by layer under the PFCL and the silicone oil, very well managed.
Thank you, Morris.
Other way around, my question is, what about the silicone oil induced glaucomas? Any incidents you had seen in your practice?
Good question, Morris. But as I explained, these don't go in for glaucoma, rather they go in for hypotony. These
Correct.
very severe cases, they have ciliary shutdown. So most of these cases, whenever we operate these very high-end PVR or grade D PVRs, most of these cases, as I have seen, very rarely they go in for the glaucomatous changes. Because I have seen, as this eye keeps growing, the other eye, so this eye becomes stunted because this doesn't grow forward. And because of the silicone oil, it is not having phthisis, but still the globe or the structure is being maintained, or sometimes even ambulatory vision, like I have seen in these two child, 3/60 vision. One is 1/60, another one is 3/60. Although the other child, the second case I showed, went in for more severe hypotony, and it is just maintaining. So I think, in fact, we give more lot of steroids to pump up to have the to face the ciliary body shutdown.
Many congratulations, Dr. Srinivas, for keeping the Indian
Thank you, Maureen sir. Thanks for all your help and support. Thank you. Thank you, Bharti madam. Thank you,
Thank you, sir.
Devesh.
Thank you,
And
sir.
thank you, Dr. Bibhuti.
Excellent, sir.
Thank you,
Pleasure
Shubhav.
was all ours, sir.
Thank you,
Thank
sir.
you. Thank you, Maniar sir, and all the expert panelists
So
for
we
having
move.
me here. Thank you very much.
I request you all to stay here because after the last presentation of the International Hero session, we are going to take the faculty talk from the discussants. And discussants are, we have done introduction of discussants. They all are very brilliant. From Maniar sir to Devesh Kumar to Dr. Ruchi Goyal to Dr. Pranita Sahai, everybody is so brilliant. So, and then our own JHOS speakers, Dr. Anindya Anuradha is here, Dr. BP Kashyap is here with his multiple cases compiled in one presentation. So please stay with us. Don't leave the platform. So now over to Dr. Shubha. Dr. Shubha?
Yes, ma'am. There.
Yes. And for Dr. Shubha, anybody can be discussing because it is a general ophthalmology topic. Dr. Maniyar sir, be prepared.
A very good evening to everybody on the panel. Thank you so much for this opportunity. It is really a great honor to present among all the dignitaries present on the panel today. I shall be speaking on the efficacy of intravenous methylprednisolone and pulse steroid therapy with oral immunomodulation, which is a protocol-based approach in patients with active thyroid eye disease, moderate to severe. This was presented at both the American Academy and the Asia Pacific Academy 23. As we all know, that thyroid eye disease is also termed as thyroid-associated orbitopathy. It's a progressive disease where there is a constant interplay between the orbital fibroblasts, the glycosaminoglycans, and the immune reaction of the body. And inflammation takes the center stage in thyroid-associated orbitopathy. So how do we go about addressing it is with the use of oral and intravenous steroid therapy, which form the mainstay of treatment. The aim of the study was to take over the efficacy of the intravenous methylprednisolone in a pulsed manner and at 3 weekly intervals. And this, when required, on sequential examinations when the patient comes to the clinic, on our subsequent follow-up visits, we decide upon oral immunomodulation in a controlled and a continuous manner such that there is a gentle handshake between the steroid therapy as well as the immunomodulation. We did this study in a retrospective manner, reviewing all the case reports of active thyroid eye disease from our institute, which is over a decade study involving 147 eyes, and the inclusion criteria was to involve only those patients with moderate to severe disease. This involved a comprehensive clinical radiological analysis where we performed a detailed evaluation, as we will be seeing further, and the intervention when required in an active thyroid eye disease was taken up in the form of a medical management, and we shall be restricting today's talk to the medical management of an active thyroid eye disease. The series involved individuals which were largely from the 4th to 6th decade of life. And compared to the other series, there was a higher proportion of males in our study with a relatively less or low on profile on the smoker list, and with 50% of these constituting a hyperthyroid status at our presentation. So the intervention was when there was active thyroid eye disease, and the clinical activity score was more than or equivalent to 3 on the baseline presentation, which is evaluated out of 7 parameters. And the medical management involved the use of a pulsed intravenous methylprednisolone with a loading dose and a maintenance dose. The loading dose involved the pulse 1, wherein the individual received 3 subsequent doses on day 1, 2, and 3 of 500 milligrams each intravenously, and subsequently at every 3-week intervals received the other pulses till he completed the pulse 6. Total receiving about 4.5 grams of intravenous methylprednisolone. And this was coupled with oral immunomodulation, depending on how the patient fared after the 3rd pulse typically, or in certain cases which presented with a severe thyroid eye disease active with functional problems and ocular motility limitation in the primary and in the reading gaze. They were initiated on the oral immunomodulation on the 3rd pulse itself with azathioprine and mycophenolate mofetil. Mycophenolate mofetil having a larger safety profile as compared to azathioprine. The intervention in about 70% of our patients, we went ahead with oral immunomodulation coupled to the intravenous methylprednisolone. And we were looking primarily at 3 outcomes. One was reduction in the exophthalmos which in our series was at the range of 1 to 9 millimeters and the mean being 2.7, as seen in this photograph in pre and post completion of 6 cycles of intravenous methylprednisolone. 2 is a decrease in the clinical activity score, and the range of the follow-up in such cases ranged from 6 to 47 months with the mean as shown. And there was a reduction in the clinical activity score by 4 points when combined with intravenous as well as oral immunomodulation with azathioprine in this case. Third, as seen, ocular motility limitation improved. Baseline, the chart shows that there is diplopia, and following treatment, you may notice the improvement. Based on these 3 outcomes, when compared to the other studies, larger studies that we have, we had a higher proportion of improvement in the clinical activity score when combined with oral immunomodulation. Thus, in conclusion, in an active thyroid eye disease, the low-dose monitored pulse IVMP with a short-term oral immunomodulation in a continued and a controlled manner is a good option as a primary line of management. The idea of giving a pulse steroid therapy is that you want to address the circulating T lymphocytes at 3 weekly intervals, knowing that the half-life is around 21 to 28 days. And the second is that because we are using a low dose, say 500 milligrams intravenously, it is a safe and an effective manner in which we control the disease activity, which aids in resolution of symptoms like double vision and also improves the ocular motility without having major side effects systemically. These are the references. Thank you.
So, Dr. Prasad, hi, nice study. But you know what I've noticed is that although mycophenolate is quite well tolerated, there would be some patients who would not be able to tolerate, and still, there are dropouts. And so, how do you tackle those kind of patients? And if suppose the diplopia continues to increase despite your therapy, what is your next line of management?
Ma'am, the question 1 in which you just mentioned about the safety profile of mycophenolate mofetil, the idea is to use, possibly can also use azathioprine as the other option, which is 50 milligrams twice daily dosing. And this is typically given for a longer time, say 6 months to 1 year also. However, at every 3 weekly intervals, we request the patient baseline before initiation of therapy, and also at every 3 weekly intervals, we request to undergo a complete blood picture where we monitor for any possible neutropenia or lymphopenia in that case, 1. 2 is that if the diplopia continues to improve, like ideally we would want to reinitiate intravenous methylprednisolone, 1. Second is if we know that our on our treatment, despite being on our treatment and maximum intravenous steroid therapy, in our cases of severe thyroid active eye disease, we have also tried rituximab. And this is given typically in 2 cycles. 1A, 1B is the first cycle, and 2A, 2B constitutes the second cycle, which are 6 weeks apart. And this has shown us good results. The study is still on, and then we might publish soon upon that.
Okay, and any your experience with radiotherapy?
Ma'am, we don't do radiotherapy at our center, although literature kind of has documented the use of radiation in thyroid eye disease. 1, because we are at a risk of causing a bystander effect to the other eye as well. Second is we might induce radiation retinopathy. Third is that most of these patients also have this metabolic syndrome where they have high blood sugars, uncontrolled blood sugars as well. So this can accelerate diabetic retinopathy in these cases.
Okay. And what about patients, if the, you have, the patient comes back with a relapse. So how far, what would be your interval where you would repeat your IV pulse therapy again?
Ma'am, relapse as in like we would always monitor, irrespective of the therapy, no therapy, we would still monitor him on a regular basis. And we know that when the relapse has occurred, we would reinitiate on IVMP, because now we know that we have still utilized just 4.5 grams in the first 6 cycles. We still have potential 6 more cycles to go. The only reason or only place where you want to initiate on a higher dose of intravenous methylprednisolone would be sight-threatening dysthyroid neuropathy at time of presentation, or either directly go ahead with endoscopic medial wall decompression to relieve the orbital pressure.
Thank you.
Great presentation, Dr. Subhav. So, any experience with the periocular Kinacot and the subconjunctival Kinacot in thyroid eye disease?
Thank you, Dr. Maurya sir. That's a good question. We do this in terms of addressing the lid retraction, where intra-LPS triamcinolone acetonide is given, and we follow up the patient. And after following the injection, also there are specific instructions which are laid down, which the patient is supposed to follow. And then on regular follow-up, if we ever have to repeat, we do it for a maximum of 3 times, and that usually settles. A colleague of mine has done a study related to the intra-LPS triamcinolone and was presented at AIOC, which really has shown some brilliant outcomes, which even we were not expecting when we started doing it.
So, means what about the repeatability? Means
We do it for
long
maximum.
follow-up.
We do it on three times, and we after having given the first injection of intra LPS triamcinolone acetonide, maybe we repeat the second time only after 3 months.
Okay, after 3 weeks.
3 months.
Okay, okay.
I think we also did a study. We repeated after 6 weeks, but then again, you know, the effectivity is not. I don't know. We didn't find it as comparable to the pulse therapy, but yeah, would be done in selected patients where they would not.
You did that in the LPS, ma'am?
No. We were giving periberber.
Okay.
No, I was talking about intra-LPS triamcinolone acetonide to address the lid retraction, ma'am.
Only lid retraction. Yeah, we understood that. Yeah. We understood that.
I will just stand corrected on that. That's it.
Arshad, one question.
Yes, sir.
Clinically, is there a return of the corneal sensations?
Sir, to my knowledge, as far as I have seen patients, if we are talking about a corneal breakdown at the time of baseline presentation, or are you talking about a normal active severe thyroid eye disease?
After the thyroiditis that you showed the scores.
Yes, sir.
The sensations would be diminished.
Now,
after your therapy.
Yes, sir.
They return, if so, to what extent? That was a clinical
Correct.
thing, not something that you measure with your biomedical markers.
Yes, sir.
Old people ask clinical questions.
I think they do recover, sir, but personally, I have not studied it. I'm not in a right position to tell you right now about
Thank
it.
you.
It would be false if I say something on that. I would not want to comment on it right now.
Thank you. And that concludes.
Maybe Dr. Ruchi Goel can opine on this if she.
Yeah, actually, sir, I have not experienced that decrease in corneal sensations in these patients
at all.
At all. No.
Yeah, baseline as
I have. That's why that is one of the reasons.
It must be, it must be not very common then, sir. Maybe it must be occurring in some patients, and especially with exposure keratopathy prolonged or something like that. But otherwise, routinely, no, sir.
Absolutely. In exposure keratopathy, I had also observed.
Okay, sir.
Yeah.
Thank you, sir.
Thank you.
Thank you very much, sir. So our last video is going to be by Dr. Amar Pujari, and he would be showing his video on evaluation of true muscle transplant versus novel hang back resection in extra large angle
Wait. Dr. Amar Pujari is not here.
Oh, okay, ma'am.
So we are completing the session.
All right.
And all the talks have been delivered very nicely and discussed very nicely. And now we are starting the second session, that is the JHOS potpourri. And we have taken the guest faculty's lectures also in that. So now
One request, ma'am.
Yes.
One group photograph, one screenshot. Can we have?
Yes. डॉक्टर रुचि, अरे सब लोग आओ भाई, खिड़की खोलो, प्रणीता को भी बोलो.
Sure, ma'am.
मित्रा जी, secretary.
IT people, kindly, could you please do that?
IT people, सबका विंडो खोल दीजिए.
with the Queen of Ophthalmology, Indian Ophthalmology, great honor, and with the esteemed and honorable presidents, ex-presidents of Jharkhand Society,
Done,
secretary,
sir. Done, sir.
moderators.
Conference hall. Yes, conference hall is there. अरे वहां पे लाइट वाइट लगाओ भाई.
IT people, could you please do it as early as possible?
राशि, I
Not
cannot
today.
see you.
Already
राशि,
done.
तुम भी बैठो बगल में. Okay, she's there.
Conference hall,
It's
hall
done,
is
sir.
deliberately being kept
Thank you.
dark.
Thank you.
नहीं नहीं, एक्चुअली कॉन्फ्रेंस
डॉ-
हॉल वाला लाइट जो है ना, वो डॉक्टर
डॉक्टर
दीपक कश्यप ले
डॉक्टर
गए हैं.
कश्यप बैठे हुए हैं वहां पे, कुछ जरूर चक्कर है, इसीलिए वो डार्क रखे हुए हैं.
वो लाइट लगवा दिए हैं अपने प्रेजेंटेशन के लिए लाइब्रेरी में. वहां पे सारे लोग हैं. वहां पे देयर आर 5 पीपल. राशि,
people.
श्याम,
Yes, yes.
दीपिका,
I am seeing
everybody is
that.
there.
Yes, yes.
हो गया जी.
Thank you, Sunil. Thank you, Sunil.
Ma'am, can we start the potpourri session?
Doctor
Yes.
Dr. Maurya, you have taken the picture.
Yes, ma'am. Thank you so very much.
And
And thank
अरे
you so
अभी
very much
रहो
for the
बेटा.
opportunity.
अरे भाई भागो मत. अभी डिस्कशन बेचारा तुम लोग में इतना रहा, तो डिस्कशन में आप लोग भी रहो.
Thank you,
अब
Arvind.
देखो मनियार सर कितना बढ़िया अभी टॉक देने वाले हैं.
Ma'am, I always keep this Karwa Chauth fast along with my wife. So
अच्छा.
just allow me for 15-20 minutes.
Okay.
Thanks,
Really?
Arvind. Thanks a lot,
अरे
Arvind.
Thank you, sir. Thank you, sir.
You
Thanks,
keep
Ranjit.
fast. अच्छा चलो ठीक है. तो over to Dr. Rashi Shyam. Over to Dr. Rashi Shyam for coordination of the next session.
So good evening, everyone. I would like to invite our chairpersons, Dr. Rajmohan sir, Dr. Pritish Pranay, Dr. Anand, Dr. Malay Dwivedi, and Dr. Ratnesh.
थोड़ा थोड़ा इंट्रो दे दीजिए, दो लाइन.
Rajmohan sir is one of the very senior members of our ophthalmological society. And sir, are you there here today? Dr. Pritish Pranay?
Yeah.
Yeah, Dr. Pritish is here. He heads our IT managing of the website and everything, and is a very active participant in the JHOS committee, both executive and organizing committee of most of the conferences and webinars. Then we have Dr. Anand Sushrut, who is a very popular practitioner, and Dr. Malay Dwivedi and Dr. Ratnesh, all of whom are prolific anterior segment surgeons. So we have first 4 talks by our invited faculties. They are stalwarts in the field of ophthalmology. The clarity, the wisdom, and the diction with which they speak, it is always a pleasure to hear them. The first talk, I would like to invite Dr. Rajit Manyar, sir. We've had all the faculty introductions. So, sir, can you please start?
I'll do that. I'd like to share my screen. First, I go to share screen, right?
Just a quick question. How did you develop your interest in system analysis?
Pardon me?
Sir, you are a system analyst right now. How did you get so interested in technical part of our field?
Logic and common sense. You look at a problem, you realize where it lies, and then you correct it. It's just plain logic. So, voice is clear, I hope. Hello, the voice is clear?
Sir, audible, sir.
Audible?
Yes,
Yes,
sir.
sir.
Audible.
Yes, sir. Okay. Bharti, thank you for pulling an old man out of a VRS situation. I had given up public speaking since the COVID days, but I think if nothing else, Bharti, you're very, very forceful. So thank you, Jharkhand Ophthalmic Society and Bharti, for pulling me out here. We are discussing something called product costing, service pricing. And I do have a declaration that I have an interest in your financial health. Now, doctors generally suffer from a lack of knowledge of matters concerning finance. They may know the best way of iron peeling, but where matters of finance are concerned, they're really poor. The basis of pricing any product, an industrial product for that matter, I have some experience with industry too, is the raw material that goes, the direct costs, the processing, the facility where it is processed, the packaging, the dispatch, the utilities, etc. Now, when you talk of a medical product, the raw material is your medical learning. The cost of sorry, I got one back. Processing is your skill set, additional skill set, and your experience. The faculty facility is your clinic, daycare, nursing home, hospital, and the depreciation remains the same. Packaging is equivalent to your staff and the benefits that you pay them. And your licenses, insurance, and your utilities remain the same too. Again, you have a cost of marketing, you have a cost of finance, you have a cost of recovery of your money, especially if it's an insurance company. There is depreciation, and there is something known as a markup, which I'll allude to later. Now, when you come to medical service, this was a medical facility costing. Now there is a service costing. Sir, there are three issues here. One is you talk about the facility cost, you talk about the service acquisition cost, and the third is you talk about the service delivery cost. So we are talking now of the service part of it. It would vary with patient loads and volumes. The price of patient care, I'll allude to this. It is stress, medical legal issues, stress-induced diseases, metabolic disorders, etc. When you are young, Ruchi, you won't feel it now. But as you grow older, you will realize that you have accumulated stress because of a hell of a lot of devotion to patient care. So you also need leisure time, and most important, you need a return on investment. Again, I'll allude to this also a little later. The facility cost is like a cost of the asset, cost of finance, functioning of the asset, ancillary costs, etc. The land, building, equipment, FACO, microscope, blah, 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 all that is there. The cost of finance. Now here, there is generally a lot of hidden costs, especially when you negotiate with banks, etc. And this last minute, they tag you with hidden costs called surcharges and processing fees and things like that. And these also need to be costed, especially when you're on borrowed funds. The cost of functioning of the facility, these are the standard things, but never forget to cost for HR training, because this will go a long way in the functioning of your center on a very, very smooth basis. Then there is depreciation, there is maintenance. Now, maintenance cost is something that you negotiate with the initial purchase, and you negotiate it for 10 years. When you're buying a piece of equipment, the company will negotiate everything for you. After you bought it, they will screw you on these parts. So the first thing that you do is negotiate it, the maintenance cost, and finally come to the warranty, and then last you negotiate the price. Miscellaneous is electricity, water, rent, rate, taxes, administrative and marketing costs. There is audit and insurance. And now there is also a legal cost. I think everybody needs to, maybe once in 2 years, you're likely to have a legal issue and you need to cost it right now, right at the outset when you are young. Don't wait till you're old. Even I got hit with a legal issue for want of nothing at all. I mean, I was exonerated, but it hits you. So when you're looking now at the service cost factors, is the cost of education. That is your tuition fee, hostel fee, coaching fee, PG tuition fees, etc. And also don't ever forget that if you are on capitation, there are other fees also that you have to take into account as part of your costing of the cost of education. Price of theoretical learning is something that you have to learn on your own. It's not something that somebody can teach you and spoon feed you. You have to learn this on your own. Then there is skill acquisition. One is theory, the other is skill acquisition. So the skill acquisition costs, the basic skill set, you already have innate ingenuity, you have innate skills. These you are born with. Now, your gurus in PG, your gurus at undergraduate level, etc., they sharpen these innate skills and make you a very effective doctor. Then there is the additional skill that you acquire. I have seen so many of your speakers who have got fellowships, FICO, ICO, etc. And these additional skills also, they these additional skills also cost money. So these need to be costed in also. Patient care. There is a price, emotional price for patient care, and Janumet XR is a classic example of delayed onset diabetes, metabolic disorders because of a lot of involvement with patients. You must have an allowance for leisure time. And now let's talk about markup. What is markup? If the cost of the product or the service is say 100, how much more should you sell it for? That is the markup, that is the profit. And mind you, profit is not evil. Profit is normal, profit is expected, and you are expected to cost it also. So what are the industry norms for these markups? In the farming sector, it's pretty low. In the manufacturing sector, 8, 10, 20%. But lo and behold, in the service sector, TCS, etc., they have a markup between 40 to 200%. 40 to 200% markup of a service. Return on investment. You put money in an FD, you put money in your mutual funds or equities, and you titrate the return on investment and you keep monitoring it. The same way you have put a hell of a lot of money here into your own establishment and you need a return on investment here. Oh, sorry. So what should that be? Well, that depends with the number of dependents that you have. More the dependents, the greater the ROI that you look for. Patient volumes. More the patient volumes, less will be the unit cost to the patient. How do you ultimately then cost a medical service? Not peanuts. Today we are paying, we are charging peanuts. We are really charging peanuts. Our skills, experience, the stress, the leisure, the markups, all these are to be factored in. Compensation or the cost is modified and tempered by certain patient variables like what are the risk factors? Is there, he has 2 stents, he has hypertension, he has diabetes, he has medical problems, he has a legal problem, he's likely to get violent, he is related to some MLA MP. Then the volume of patients, and finally, socio-economic issues. Have a heart. If patients can't afford, be generous in your discounts, but be aware that your original price should be, say, X, and you are giving a discount of Y. You should be aware of what you are owed. Next is competition. What do you do with competition? This is the bad way to approach competition. Don't ever look at your competing colleague in this way. Rather, hug your competition. Hug your competition and have a mantra where मिल के कमाओ बांट के खाओ. The operative words are मिल के and बांट के. Have very healthy competition. Have no price cutting. Have no bitching. Don't run down your colleagues. And there is enough. The cake is large enough for multiple slicings. So don't worry on that. Now here there are certain figures that I have put. These are Mumbai centric. In Jharkhand, maybe it may be 30 to 50% less. Take your calls on that. But it's 16.2 here crores. It's about 1.62 crores on the OPD facility, 1.98 or 2 crores on the OT facility. This is only the initial outlay that you put in your facility. The running costs when you come to with just a markup of 20%. And annual patient load, I've taken a very minimal load of 2,000 patients in the OPD annually, 200 surgeries annually, and you look, the facility cost is 2,800 for an OPD consultation, 61.6 thousand for a cataract surgery, the facility cost. Now add to that the skill acquisition cost. These are your fees that you paid, etc., etc. And your markup here, because it's a service industry, your markup is a modest 100%. You apportion it to OPD and OT in 1:2 ratio. And again, at 2,200, you're looking at adding maybe 480 rupees and 950 rupees here, 9,500 rupees here. Finally, the skill and facility cost comes to about 3,300, 71,200. I repeat, these are Mumbai figures. They would be marked down where Jharkhand is concerned or any other position is concerned. You have to take your existing prices of land, building, etc. there. Now, what in this case, what is your, you've taken a 20% markup, you've taken a 100% markup on service. So what should your final return on investment be? Do you think it would be around 80 or 90%? No. It's a measly 40% return on investment only. This is for facility and service acquisition only. We have not yet discussed the service delivery charge. Now, when you have pricing of service delivery, look, you have the consumables which are billed. Generally, we build them at cost, but if you are a company, you can build them at MRP also. I take 10,000 as a minimal surgical fee for a beginner. 10,000. With each year of experience, I add 5% to that. Patient risk factors, with each risk factor, I add 5% to that. Patient's socioeconomic, if he is poor, please discount these prices. But discount the service cost. You can't discount the facility cost. If there are other factors like you have a troublesome patient, you have a neta, and please charge him, just give him surge pricing. And now the life's ultimate truism I give you, it's not the beads, it's not the malas. Guess what? It's the beard. Beards make things better always. Now to conclude, don't thank me please for this. I want you to get your act together. This photo represents life. There is a pigeon and there is a statue. Every day the pigeon shits on the statue. The statue can't do anything about it and you have to take it. In life, You have pigeon days and you have statue days. Sometimes you are a statue, sometimes you are a pigeon. So, what I wish for you is have a great pigeon day. Thank you. FBS is something that I'd like more people from Jharkhand to join. Bharati would give you more details. And Kuresh, Rajiv Mukherjee, Sharad Babu, or Satanshu Mathur can also give you more details on that. Thank you all. Thank you very much.
Thank you, sir. It was a wonderful, talk. So, because this topic is very related to my study, can I take up the discussion, please, Bharti ma'am? Can I have the question?
Yes, yes, yes. Please go
Yeah.
ahead.
So it was, sir, actually kind of 2-year MBA course get short to 5 minutes presentation. Very nicely done, sir. So, sir, as you said, it's of Mumbai presentation, like the calculations that you have taken, the ROI factors and all the financial factors. So, considering that where volume is so high, it's coming to the Jharkhand. If you see the catchment areas, the segregations, and the volumes are compromised. So, how will you find your competitor analysis and strategy?
I would only give you the headings. The figures are something that you need to put yourself based on local conditions. Your patient volume, your OT volumes are your own. Your facility cost in terms of land, building, the HVAC and the other things that you want to spend on, they are all on your own. So those are all variable factors which vary from, say, Delhi to Mumbai to Chennai to Ranchi, Patna, wherever you are. These things will vary, and that's where you have to come in and do this actively on your own. Just making sure that the three things are taken care of: the facility cost, the skill acquisition cost, and the skill delivery cost. You have markups and you have ROI, and you never feel shy about them, never feel guilty about them, and there is nothing unethical in charging what is owed to you.
Thank you, sir.
Poor
That's
patient,
great insight.
poor patient, you can even forego all your charges. In fact, you can cost at 10% free patients. You can even cost that. If you want, you can cost that also. कि 10 पेशेंट को फ्री दिया तो उसका भी कॉस्ट हमने बाकी लोग पे लोड कर दिया. There are factors like diseases which come up. When you are young, you think you are absolutely healthy and nothing is going to go wrong. But it's not so. You do get stress diabetes. You do get hypertension. You do get renal disease. You do get metabolic disorders. You do get, say, um, you know, weak bones, etc., fractures, falls, etc. I don't wish it for any of you guys, but these are things that happen. And these are things that have to be costed in right at the outset. Even the legal fees have to be costed in right at the outset.
Yes, sir. So insightful, sir. Thank you, sir, for sharing.
Thank you. Thank you so much. Thank you.
Sir, I should congratulate you for giving an eye opener for this sustainability actually. Sustainability of our practice. This is very important for the beginners and also for the mid level practitioners.
Yes, for all of us.
And along with the yes, sir, and along with the if you grow old and you are in the field of quite some time in the field of practice, you should know the how to slow down your practice also.
That's
What is your take on it, sir?
absolutely. I work now only 3 days a week.
Thank you very much.
I have an extended weekend which starts on Friday evening and goes on till Tuesday morning.
Yes.
So you slow down because really that's enough that you've had. You had enough. You earned enough. You're doing it now only for the fun of it, to stay active.
Yes, yes, sir. You should love your practice and you should love your life also. I mean, lifestyle
Oh, yes.
also.
Oh, yes. Absolutely.
Thank you, sir. Thank you very much.
Thank you. Thank you. Can I take your leave, sir? It's diabetics dinner time. So if you'll excuse me. Thank you. Bye-bye.
Sure, sir. Sure. Bye bye, sir. Good night,
Thank you
sir.
again to Jharkhand Ophthalmic and to Dr. Bharti and all of you. Bye-bye.
I think Dr. Rashi should call upon the next speaker.
Dr. Rasi, you are on mute actually, so that's why it's not audible.
Dr. Rashi.
You are still on mute.
Yeah, Dr. Ruchi Goyal, ma'am, we would like to welcome you, and we are waiting for your talk on orbital tumors now.
Yeah, thank you so much, especially Bharti and of course the entire JHOS society, and it's been a pleasure to be here today. So I'll start with my presentation. So I shall be talking about, the orbital tumors, how to approach. And whenever you have these patients coming up, and all the history and examination basically is based on making a tentative diagnosis and to decide whether you want to go for incision or excision biopsy. Also, whether it's a benign or a malignant tumor, that will decide your urgency and follow-up. Also, whenever you have a mass, you want to know exactly what is the extent, what is the location, what is the extent of the mass. If it's a malignant mass, then you need to do a TNM classification also. So, patients of lymphoma, you really don't need to go think about approaches, because wherever you can take a small FNAC or maybe sometimes incision biopsy, you can easily get a place. These tumors are usually conformed to the orbit, and these are usually, you can see they're homogeneous tumors, and the age group would be an older age group. Again, rhabdomyosarcoma, again, you don't need to go for excisions. You simply need to take a small biopsy or an FNAC, and these patients would undergo systemic chemotherapy or radiation. Then patients of sarcoma, where this is a patient with frozen orbit, as you can see on the right side, there is a large mass. Here, sometimes whenever you have a confusion before you try and do anything specific, you must make a diagnosis. And again, you can just go in for an FNAC, ultrasound guided, or an incision biopsy. Whenever you're thinking of taking out or excising a tumor, then you need to really see whether the mass is intraconal or it is extraconal. And whenever it's an intraconal mass, we usually ascertain whether it is in the anterior 1/3, middle 1/3, or in the apical zone. Masses only limited to the apical zone may be difficult to remove for an ophthalmic surgeon and may require the help of your neurosurgeons also. Now, these are the conventional incisions which we are using quite often. The commonest nowadays, as we all work on producing cosmetic incisions, so these are the conjunctival approach for a medial or orbitotomy. Again, a transcaruncular approach. Sometimes you do need to go in for a skin approach also. This is if you have deeper lesions in the intraconal area also, this vertical lid split really comes in handy. Gives a very good exposure. Any deeper lesions in the lower orbital area, the swinging eyelid crease incision is very handy. And nowadays, I think very few cases are dealt with a skin approach. Most of us are doing it through the conjunctival approach. In the lateral orbitotomy approaches, nowadays, we have all more or less shifted to this is the upper lid crease approach. Otherwise, again, in some cases, you may go in for the standard stellarite skin incisions. I'll show you a few examples. Now, this is a patient where this was an atypical liposarcoma, and this patient, I had to do a debulking. So this is a transconjunctival approach, and this is a very interesting case where we were actually, the patient had come for exenteration. We thought of doing a debulking. We never expected the patient to settle down, but just look at this picture. This is not 3-4 years follow that is there, and this patient actually came for ptosis correction afterwards. So this is post ptosis surgery. So I debulked it twice or thrice. So Again, whenever you are resecting any tumor, you should take care not to injure any of the adjacent structures. This is a patient I recently operated. This is a medial orbital mass. You can see, and this was compressing the optic nerve. The vision had already fallen to 6/18, and it was way back. So what I did was, in this patient, this came out to be a cavernous hemangioma later on, but I had to go through a skin approach, and I had to give an incision in the medial orbit, this medial canthal tendon also. So sometimes you have to err towards not only cosmesis but towards a larger incision to take out the mass in toto without damaging the adjacent structures and without breaking the mass, breaching the capsule of the mass. This is a patient, again, I recently operated. She came with a superior orbital mass, and this mass was extraconal. And you can see this is going right till the orbital apex. It was actually a frontal nerve schwannoma. And there was no way other than taking out through a vertical lid split incision. So she's doing well now. This is another patient where there was a mass you can see in the inferior orbit, and the mass has pushed the globe upwards. And this is a swinging eyelid crease incision. This is a very useful approach where first this is the RF knife being used and the lateral canthotomy has been done. The mass is very gently dissected, and this is the lens spatula, very blunt, always a blunt dissection, hooking your inferior rectus through in this approach always helps, because you should be careful not to injure the muscles or any of the tissues, even the inferior oblique if you're going a little more medially, which it crosses across. So this is the mass which you can get a very good approach, a very good view in this kind of an approach. Now, this is a child, one has to be careful. This came with the inferior orbital mass, and actually this is again a vascular malformation. So he came for excision, but when I got a Doppler done, I could see the arterial waveforms. And if you see this picture, you can see the Valsalva is also positive. So initially it was considered as a venous malformation, but you should always be careful to get a color Doppler and ensure that there is no major arterial component. So ultimately, this patient had to be the arterial component has to be dealt first by coiling or whatever procedure, and then you have to go in for surgical intervention. Another patient with lateral orbital mass in the extraconal compartment, a typical lateral mass of the lacrimal gland. You can see the bone is quite smooth and it is a well-defined mass. This came out to be a pleomorphic adenoma. And what is important is that you should not breach the capsule and you have to take it out in toto. In contrast, if you look at this patient, you can see there is some irregularity of the bone over here, and there is some heterogeneity also. And this patient also had pain. So these are signs where you are dealing with a malignant lesion, and you should be careful. You should get a PET scan done beforehand to ensure that there is no metastasis even by the time the patient has come to you. So this is just to show how lacrimal gland mass can be removed. So this is a standard stellar right incision, and you can see it gives a very good approach. And again, once you the periosteum has to be sometimes excised along with it so that you don't breach the capsule while pulling the mass out. And very gently you need to dissect and take out the mass. Just off. So this is the mass which can be removed. Sometimes you even need to do a little punching of the superior orbital wall to get a good exposure. So this is the Goldman's technique where you need to do a little punching of the bone, and again a very good. This is an intraconal mass, a large intraconal mass which cannot be taken by any of the approaches I had shown earlier. You can see it is sitting right in the center. This also came out to be a schwannoma, and I'll just show you how this was removed. So this is a lateral orbitotomy being done, and after making the incision, the lateral wall of the orbit is exposed and the periosteum is incised, and this is the standard way by which you do a lateral orbitotomy, where the incision is given in the just the inferior border being in the inferior orbital wall, and this is the frontozygomatic suture just 3 to 4 millimeters above, and this is the saw the bone is reflected, and at the junction of the greater wing of sphenoid and the zygomatic suture. And this is the mass now exposed. One has to be again careful not to injure the lateral rectus, not to injure the lacrimal gland, which we'll be seeing shortly. So again, a very gentle dissection, very carefully. So you can see the lacrimal gland here, not to injure the adjacent structures and not to pull too hard, because sometimes while pulling out, you end up injuring the blood supply, and central retinal artery occlusion also can occur in these kind of patients. So one has to be very gentle while you're actually prolapsing. I usually am not too fond of using cryo in these patients. Yeah, this is another patient who again had a superior orbital mass, but look at the scan. So one needs to be really careful, not only to focus at the orbit, but also the adjacent structures. So this mass was extending into the frontal sinus, the ethmoidal sinus, and it actually was a mucocele. So one should be very careful to look at the adjacent structures whenever you are planning any orbitotomy. And so to the take home message is that image, all the CT and MRI, they help us in really deciding where exactly the mass is, what is the extent, what approach to use. And sometimes you really need to take help of your ENT colleagues, your of course the radiologists, the pathologists, and sometimes the neurosurgeons. So you need to really have a team to work in. And the incisions, usually we prefer cosmetically acceptable incisions, but if required, if it is at the cost of breaching the capsule or removing the mass in pieces, we would rather go for larger incisions. And a meticulous dissection prevents damage to the intraorbital structures, and one needs to be careful on table. Also, you should keep checking the pupillary dilatation, keep pressing so that no blood is collected at the end of the surgery. And post-operative, also keep a watch that there is no intraorbital collection of blood and the optic nerve may get damaged. So thank you so much for this wonderful session. And I would be happy to take any questions. You're muted. The conference call is muted.
Good evening, ma'am.
Good evening.
This is Dr. Vibhuti Kashyap. It's a very informative presentation. I just had one doubt. I wanted to ask about your take on the excisions of hemangiopericytomas. Like we have oculoplastic surgeon with us, Dr. Gautam Lokdarshi. So what he advocates is embolization of the ICA vessels, and then a day later you take out the hemangiopericytoma, so that reduces the chance of bleeding. So I wanted to ask if you also prefer an embolization. Is it a routine practice to perform embolization? And if yes, then who is the better person, a neuroradiologist or an intervention radiologist or a neurologist or a neurosurgeon? And or probably an intervention cardiologist who is good with his ICAs. So probably all that you need basically is an armamentarium of a cath lab. So what is your take on that?
I was working in MAMC. I've recently gone into practice, but yeah, hemangiopericytomas can be really a messy surgery if they start bleeding. But pre-operative assessment, not all patients I would go for embolization, but if I would require embolization, we were actually fortunate to have a good complex with the GB Pant Hospital, where all our CCFs and all these patients, mostly the neurosurgeons in coordination with the radiologists there, they were doing all these embolizations for us. So we had a team, so we were fortunate. But yeah, standalone practice, yeah, you can get into a mess. So whenever you have such, if you have such a situation, then it is better that you do it in a multidisciplinary specialty. Yeah.
So we have been doing that, ma'am, and the results are very good. We are fortunate enough to have a very excellent oculoplastic surgeon with us. But my doubt actually was that how does this embolization fare as compared to probably a sclerotherapy? Maybe do you think we should fathom
not all I have taken out hemangiopericytomas. Not all hemangiopericytomas bleed to that extent. But on table, if you feel you can make use of these things. But routinely, I'm not doing ICA embolization in all patients. No. And maybe, you know, in once in a while, there would be something of this kind, but you don't subject all these patients for ICU embolization.
Thank you so much, ma'am. Very informative.
Ma'am, for a general practitioner, I just wanted to put one question. Like normally these cases, if proptosis is there or we can palpate a mass, we like to refer to an oculoplasty surgeon. Should we image at that time or not? Because the cost of imaging is also significant when it is a low socioeconomic patient. And suppose I get a CT done and the person needs an MRI. So should we just refer directly or should we image and then send?
Actually, if you put it that way, it's either way, you know, because if the patient comes with the incorrect scan, and mostly what happens is, like, suppose I look at a patient and I want to focus on the bones, and mostly the tendency is to order an MRI. So again, you know, I have to go for a repeat imaging. Other than that, you know, not all centers do a very good imaging. So whenever there is an oculoplastic surgeon, and you know, every image is important. We need to know exactly. In fact, most of the time I ask for a CD and see the DICOM myself, because I need to see different you know, planes and everything, I need to check up myself. So simply just carrying two scans do not help me. So it is, of course, better that you get a, you know, you refer directly. But again, most of the, I think, even if I say that, this will never happen, because always we end up having scans with the patient when the patient is referred to us. And you may require a contrast enhancement, and it'll be, you know, sometimes just a plain CT. So that is another problem. Again, you have to go in for a next procedure and increase the cost of the patient.
Excellent presentation, Dr. Ruchi.
Think on the first time, ma'am, we should do a CT. And then if you think that it is not manageable by you, then only you refer the cases for the further management.
Not all patients would be requiring CT. That's what I was trying to say, that some patients, like, you know, when you're looking at vascular masses, MRI is a better, any soft tissue masses, basically MRI is a better choice. Then if you want to see whether there is any contrast enhancement or not, suppose vascular malformations, inflammations, you need a contrast enhancement. Then if you're looking at a mass, you want to see the bone, whether there is any erosion of bone, then you require a CT. So again, as I said, if you just order a CT, it may not suffice. So simply giving, you know, and repeated CTs, suppose I've already got a non-contrast done and I required a contrast enhancement, the patient will have radiation again for another, you know, another imaging. So, you know, I cannot give a blanket statement that you should get an NCCT done for all patients. And sometimes you need to look at the PNS, you need to look at the CT head also. So that is another problem that occurs.
Okay. Thank you so much, ma'am.
Ma'am,
May I ask one question?
Yeah, sure.
In case of, let's say, venous hemangioma, there is no pulsating mass. And initially, we used to give boiling water injections and it used to subside. What is the current trend on that?
No, we don't do any such thing nowadays. No. It's very easy to remove these masses. I don't know. I have not, at least in my era, I've never given or seen anybody doing that.
Okay.
So can we move on to the next topic now? I would like to invite Dr. Devesh Kumawat for his talk on evidence-based management of AROP. Dr. Devesh, are you there?
Yes, I'm just trying to share my screen. Is my slide visible?
Not yet.
So by the time he is getting ready his slides, may I ask one question with Kashyap sir?
Yes.
Regarding this achievement of financial freedom for the doctors, for the ophthalmologist, what is your take?
Aisa, did you ask some question? Please repeat that question, yeah.
How to achieve financial freedom as an ophthalmologist?
Financial freedom.
Yes, anyone can answer this question. Maniyar sir is not there.
He was the correct person to answer your question.
Okay.
So is my slide visible now?
Yes.
Sir, regarding the financial freedom, are you talking in terms of organization or a personal financial freedom?
Organizational as well as personal also, because we talk about because the decade younger my cousins who did IIT MBA from IIM and all that, so they are about to achieve that financial freedom. They don't need to work anymore. They can retire so early in their 40s only. So it's very difficult for us ophthalmologists. So that's what I wanted to ask.
Yeah, sir. It's like somehow I understood like after my MBA only that actually we do not invest on time and we invest in one bucket. We should be investing in multiple, and it should be like we should understand the value of small, mid, and large cap. Especially in our younger we should be investing more in small, and middle age in medium, and obviously when we are about to retire, so our value of money is really high for us. That case we should be getting going for large cap. Saying so, like the ratio has to be fixed as per our situation. Yes, definitely it is possible. That is what I will say, that I have started very late, but yes, it is possible.
Thank you. Thank you so very much.
So, Dr. Devesh, please start.
Thank you, Dr. Rashi. So I would like to thank Jharkhand Ophthalmic Society, Dr. BP Kashyap sir, Dr. Bharti Kashyap ma'am, and Dr. Rashi for giving this opportunity. So I'll be talking about the evidence-based management of aggressive retinopathy of prematurity. So this term is quite new. So earlier in the past, it was known by the names of rush disease or fulminant disease, in which there used to happen a severe progressive ROP in the posterior part of the fundus, and universally it used to have poor outcomes. It was in 2005 that ICROP first described this term as aggressive posterior ROP. And at that time also, it was an uncommon entity, and it was a severe ROP that developed in zone 1 or zone 2 posterior area. And it had severe plus involving all the four quadrants, that is dilatation and tortuosity of the retinal vessels, both the arteries as well as veins. And there used to be flat extraretinal fibrovascular proliferations at the junction, or sometimes posterior to the junction of the apparently vascular and avascular retina. And it universally had a rapidly progressive course to stage 4 and 5 if not treated in time. Now, over the time, we have observed that AROP is not very uncommon. And if you see the data even from our country, nearly 4 to 5% incidence is there of AROP in all the screened cohorts. Okay, so the ROP would be anywhere around 30% in the screened children. And out of those, if you see 4 to 5% of the screen children will have aggressive ROP in our country. Now, aggressive ROP can also develop in bigger babies and can also develop in zone 2 involving the posterior as well as anterior parts. So therefore, now ICROP3, which recently came in 2021, it has advised that we replace the terminology from aggressive posterior to only aggressive, as it can develop even in bigger babies, as well as it can involve not only the zone 1, but even the zone 2 posterior as well as anterior areas. Now, we know that there are certain risk factors which independently predispose to aggressive disease as compared to staged ROP. And these include extreme prematurity less than 1 kg or 1200 grams sometimes, and gestational age less than 28 to 30 weeks. Thrombocytopenia, sepsis, intrauterine growth retardation, these are other independent risk factors. Now, what is more important here to understand is that early insult during the vasculogenesis phase will lead to a zone 1 aggressive disease. That is, the vascularization has only reached in the zone 1. There are mature central vessels which are there. And then immediately after that, you had the birth, and then the environmental hyperoxia led to a failure of further vascularization, which led to an insult during the vasculogenesis phase. Now, this leads to zone 1 aggressive disease. And in the zone 2 aggressive disease that we are commonly seeing these days in the developing countries occurs due to supplemental high oxygen concentration that is used in the postnatal period. Now, what are the clinical features? You will have poor pupillary dilatation in these patients because the iris may be engorged. There could be tunica vasculosa lentis also present. Vitreous haze is there. The disease could involve the zone 1, that is the posterior part, and then you have the zone 2. Also, it can involve, that is predominantly the zone 2 posterior region. Then you can have large vascular loops. So the loops are here shown by the asterisks here. So you have these large vascular loops which are also known as shunt vessels, and then they shunt the blood across the arteries and the veins. And these are commonly seen in AROP. Then you have prominent plus, that is the dilatation of the venules and the tortuosity of the arteries. You have flat extraretinal fibrovascular proliferations, and if not treated in time, the flat neovascularization can rapidly grow into the vitreous cavity and cause a tractional retinal detachment. So you don't see a stage 1, 2, 3 developing in these cases. You directly end up with tractional detachments developing from the surface neovascularizations. Now you can have very small zone 1 aggressive disease also. So in the top photograph, you can see that the macula is partially vascularized and it is partly avascular. However, in the bottom picture, you can see that hardly any retina is vascularized. It's a half zone or posterior zone 1 disease in which there is only a small island of retina which is vascularized in the peripapillary area. Now you can have hybrid disease where you have both the loops and the surface neovascularization, but also have ridge in addition to that. So that can be seen in generally in bigger babies, and more commonly this ridge tissue is present in the nasal hemiretina. In the bigger babies, again, you can have AROP. You can have AROP in children who are born with birth weight of more than 1500 grams, as well as born later than 30 weeks. And often these will have zone 2 posterior, or even loops could be reaching till the nasal periphery. Now the vessels in the center, they are mature, but in the periphery, you see a lot of plus disease which is there, and avascular loops along with surface neovascularization developing in these patients. Now, how do you manage such cases? So again, the treatment options remain the same as in any ROP: laser photocoagulation, anti-VEGF treatment, and vitrectomy. But you need a multidisciplinary approach and coordination between the ophthalmologist, neonatologist, and anesthetist, because these are the sickest of the babies, and these can develop complications arising out of the management approaches as well. Now, the laser photocoagulation has been the gold standard for ROP, but the issues with the ROP laser in cases of AROP is that these babies are very sick and they may have frequent episodes of apnea and bradycardia during the laser. There could be poor visualization due to the media haze as well as the tunica vascular lentis and poor pupillary dilatation, and therefore you can have poor laser penetration, and therefore the laser may not be possible in such babies. Now, the situation may also be troubling, as you may not know where to laser in such babies, and you can have these avascular loops which may be which may, if may be missed, may lead to reactivation or recurrence or failure of regression later on. So it is important that you make a note of these avascular loops and do laser in those areas also, as shown by the black ticks, that these are the avascular loops that you need to laser, and after laser in these loops, the disease will regress completely. Now, there is a role of fluorescein angiography because clinically you may not be able to differentiate between these loops, whether these are avascular loops or vascularized loops. So on FA, you will have capillary non-perfusion in these areas, and you can target your laser based on the depiction that you get in fluorescein angiography images. Now, other limitations of laser treatment in AROP is that you need to laser a lot of area, and that leads to a severe constriction of the visual field. So you'll have a very tunnel vision if you do laser in zone 1 aggressive ROP disease. And therefore, higher the laser, more is the anterior segment changes, and there is more induction of myopic refractive errors. So we know that proportional to the laser that is done, you get myopic refractive error developing in these babies. And with the heavy laser, you also have the risk of developing exudative retinal detachments and therefore angle closure glaucomas and cataract. Now, with the landmark trials of BEAT, ROP, Rainbow, and Firefly, now the primary modality of treatment is anti-VEGF therapy. And why it is so? Because it targets the existing VEGF and it leads to a rapid resolution of the plus disease. In addition to that, it permits peripheral growth of the retinal vessels. Therefore, you do not end up having a smaller visual field that occurs with laser treatment alone. So what are the vascular changes that occur after anti-VEGF treatment is that there is an initial phase of rapid quietening that happens within a week or so, that the pus reduces quickly. There is pupillary dilatation, decrease in the media haze, and then there is a slow peripheral vascularization that happens over a period of weeks to months. Now, there are different drugs that have been tried, bevacizumab in different dosages, ranibizumab and aflibercept. The approved ones are ranibizumab that have been approved by has been approved by the European Union and aflibercept has been approved by FDA. You can use higher doses as well as lower doses. Generally, we do not go beyond the half the adult dose, but with the higher doses, you tend to have higher risk of systemic adverse effects and retinal vascular arrest. With the lower dosages, you may end up having acute regression of disease, but then you can have risk of failure of treatment as well as reactivation as well. What are the limitations of anti-VEGF monotherapy? There could be failure of regression, there could be vascular arrest, reactivation, local adverse effects, and systemic adverse effect that would be similar if treated in adults. So the treatment failure, if the plus disease doesn't improve within 3 to 5 days or 1 week, then you label it as treatment failure. Now it could be because of the insufficient drug dosage that has gone, or improper injection technique can also lead to treatment failure. Vascular arrest happens when, suppose on the bottom you can see that is a zone 1 AROP which is there. So after injection 2 weeks, you can see that the plus disease has decreased significantly. The media has improved. The vascularization is still in zone 1, although it was previously in zone 1 posterior area, but now it has reached till the margin of zone 1 and zone 2. And at 11 weeks, still you see that the vascularization has not progressed further, and so you label it as vascular arrest. Now, what is the risk with the vascular arrest? Why are we bothered about it? Is because it can lead to future risk of reactivation, as well as if you leave these eyes, then this peripheral retina is supposed to be atrophic and can develop retinal holes, lattices, tears, and detachment in future. Now, another problem with anti-VEGF monotherapy is a reactivation or recurrence. So in this patient of zone 1 AROP, if after anti-VEGF injection at 3 weeks, you can see that the plus has significantly reduced, the vascularization is progressing further. And at 8 weeks, you see that there is a reactivation in terms of a stage 2 or a ridge that has developed in zone 2 area. Now, so reactivation could be defined as an initial, you need to have an initial resolution of the disease, and then there is a recurrence of the disease that happens. Now, it could be any stage or plus or a combination of the two. And ICROP also defines it as recurrence of any acute phase feature. Maybe it may be a demarcation line or plus disease or a combination of both. Now, why does it occur? Because the anti-VEGFs have a transient action. And if we see the half-lives, the highest is for the bevacizumab, then you have aflibercept, and then the least for the ranibizumab. And if we see the reactivation, they can happen in the anterior part, that is the progressive edge, or you can have reactivations occurring at the previous edge also. So this was a landmark paper by Helen Hittner in 2016, in which they showed that you can have reactivation occurring at both the anterior and the posterior edges, and FA helps tremendously in picking up these reactivations. Now, reactivations can happen from weeks from the injection to years after the injection. And there are certain factors that will affect this, including the type of injection, that is the reactivations occur quicker or more commonly with ranibizumab as compared to aflibercept and bevacizumab. Then the dosage, higher the dosage, you have lesser chance of reactivation. And what is the threshold used to define reactivation? Late recurrences, as I told, can occur years after the anti-VEGF therapy. And reactivation rates, again, they are more commoner with the ranibizumab because it's a shorter acting drugs as compared to aflibercept and ranibizumab. What are the risk factors other than the drug used? You have a small gestational age, smaller birth weight, early postmenstrual age at treatment. Then you have zone 1 disease, and extended oxygen use and prolonged hospitalization are other risk factors. How do you manage such reactivations? Generally, laser is a suitable treatment for reactivation in zone 2 anterior, zone 3. And if we see this case in which there was a zone 2 reactivation, and after laser 4 weeks, the disease regresses completely. So laser takes care of the disease permanently. But if the reactivations occur in the zone 1 area or zone 2 posterior area, then you may want to repeat the injection also. Now, repeat injection. So this is example where at 33 weeks, the patient, the baby had zone 1 AROP and ranibizumab injection is given. So vascularization is progressing further. At 4 weeks, you see there is no reactivation, but at a later visit so at a later visit, you see that at 6 weeks, you see there is a reactivation in terms of plus disease. So dilatation and tortuosity has happened, has started developing, but there is no stage. So this would be an ideal case in which you may repeat the injection so that there may be further vascularization. So combination therapy is another approach that could be taken in AROP patients, in which you give anti-VEGF therapy at baseline and then follow up it with laser therapy. The rationale being that the anti-VEGF takes care of the VEGF which is present immediately, and then the laser takes care of the further suppression. It suppresses the further production of the VEGF from the avascular retina. Now, laser could be performed early after the anti-VEGF injection, or it could be performed later. Now, the laser again could be a complete laser that you laser the whole of the avascular retina, but then it fails the purpose for which you have given the anti-VEGF therapy in the first go. And the second way of doing a laser could be a zone 1 or zone 2 posterior sparing laser. So this is a case in which at 36 weeks PMA intravitreal ranibizumab was given, and then we did laser at 1 week, but the laser was not complete laser. So you can see that we spared the zone 2 posterior area, and that was spared, and you can see the laser scars in the zone 2 anterior area. And at 6 weeks, you can see the vascularization has reached till the laser scars, and now there is not much risk of reactivation in such a case. Now, the benefits, they have been demonstrated by multiple studies that have been done, but majority of these studies have considered a combination of laser immediately after the anti-VEGF injection, and that to a complete laser. So therefore, the benefit of giving anti-VEGF injection in the first place may not be that much in such scenarios, because you end up having a greater field loss with complete laser as well as a higher myopic refractive error. Now, vitrectomy in aggressive ROP will be required when you have a tractional retinal detachment, or if there is a dense vitreous hemorrhage or premacular hemorrhage significant enough to obscure the macular area. The tractional retinal detachments are usually central, so you do not need a lensectomy in these cases, unlike in advanced staged ROP cases. Now, that there are certain limitations of vitrectomy because you have higher risk of post-operative vitreous cavity bleed, recurrence of disease even after vitrectomy, and rebleeds from persistent or new FVPs. So what precautions you need to take during surgery is that you need to handle the fibrovascular proliferations carefully, do a diathermy in a proper way, and you can use preoperative or intraoperative anti-VEGF. Preoperative may not be feasible because you do not want to inject and wait. Intraoperative may be more feasible in such situations. Now, even after treatment, you need to follow up these patients in the long run. And the visual outcomes will depend upon the anatomical attachment of the macula or the anatomical status of the macula, as well as the vascular development in the macula. If the macula is not vascularized, then you don't expect any good visual outcome in such patients. And then you need to watch out these patients in the future for refractive errors, strabismus, glaucoma, and rheumatogenic retinal detachments. So just showing a case in which at 29 weeks gestational, the baby had zone 1 ROP, and then combined injection plus zone 1 sparing laser was done. And at 41 weeks, you think that everything seems stable and the vascularization has reached till the laser scars. But at 50 weeks, you observe that there is a tractional detachment that is developing in the lasered area. And after surgery, the baby fared well and the retina remained stable. But this case just shows that you can end up with late reactivations as late as few months to years after the primary treatment. Now, important here is that we prevent AROP from developing. So the primary prevention aims at good ANC services and then stringent regulation of the oxygen supplementation in the postnatal period. And secondary prevention is by timely screening of at-risk infants, and tertiary prevention by prompt treatment of AROP. So this screening for AROP is a little different from that for staged ROP. So for all the children who are born less than 28 weeks or less than 1200 grams need to be screened at 2 to 3 weeks rather than at 4 weeks. That is the usual for ROP screening as defined by the RBSK guidelines.
Dr. Devesh, can we summarize quickly?
Yes, this is the last slide. So, so the management of AROP is basically by anti-VEGF injection, and then you need to follow up these patients every 72 hours till the acute phase is resolved. Thereafter, you follow up these children every 2 weeks till the high risk period is passed. And then you need to follow up these children every month till the complete vascularization has happened or the disease regresses after laser. Now, in between, if you have treatment failure, you can re-inject or do laser. And if you have a higher suspicion that the reactivation might happen, then you may perform more frequent examinations at 1 week interval as well. If reactivation happens, then laser treatment is a one-shot treatment, but even repeat injection can be given in certain scenarios. Combined laser can be performed at baseline, but then it fails the purpose for which anti-VEGF injection is given, and the deferred laser may be more suitable in such cases. Thank you.
Thank you so much, Dr. Devesh. Can we take the discussions later? Because I think there are two ladies who are waiting to end their talks. So I would like to invite Dr. Pranita next.
Good evening, everyone. And at the outset, I would like to thank the Jharkhand Ophthalmological Society and Dr. Bharti Kashyap ma'am for having me here. So I'll be talking about the topic update and management of fungal keratitis. So as we all know that fungal keratitis is a fairly common entity in our country, wherein the more common in our subgroup of patients predominantly because we fall in the tropical and subtropical region, which is one of the areas where fungal keratitis is commonly seen. Now, there are multiple antifungal drugs that are available in the market. However, the main downside remains that there is poor ocular penetration. Hence, the efficacy remains limited. Fungal culture sensitivity, although is reported in literature to be available, but it is not neither routinely available in our country nor routinely performed. Also, there is no comprehensive treatment protocol from general ophthalmologists, which makes the management of fungal keratitis a little tricky. Now, the treatment options include topical systemic antifungals as well as targeted therapy, PAC-CXL, and certain recent advances that we'll discuss. And in the end, when nothing works, TPK is what is needed for all these patients. Now, there are various group of topical antifungal drugs that are available. However, the most commonly used drugs that we see in our practice are natamycin, voriconazole, ampho-B, and itraconazole. Now, amongst these, only natamycin is US FDA approved and is commercially available in a formulated drug that is used as a prescription in fungal keratitis. It works well in filamentous fungi, especially in cases with fusarium. However, the downside is it is in a suspension formulation, leads to poor penetration, hence the need for other drugs. The other drugs like voriconazole and ampho-B, although they have a good penetration and good efficacy, the downside is they are neither US FDA approved nor are readily available in a formulated drug formulation, and it needs to be prepared. Now, voriconazole works well in Aspergillus and Candida, but doesn't work well in fusarium. And ampho-B works predominantly well in Candida, same as is itraconazole, which works well for Candida. Now, we reported all these review of all the antifungal drugs in this article, which was published in Survey of Ophthalmology. Now, when we talk about fungal keratitis, the most important study that comes to our mind is the MUT trial. That is a mycotic ulcer treatment trial 1, which was an RCT that compared topical natamycin and voriconazole. In this study, because it was a predominantly South Indian-based population in which the study was done, the fusarium keratitis was the most common entity noticed in this study. As a result, natamycin performed better than voriconazole as it required less TPK, less perforation rates, and better BCVA was noted in this group. Again, when we look at the systemic voriconazole, the effect of systemic voriconazole, the MUT2 trial assessed topical natamycin with voriconazole in combination with oral voriconazole versus placebo. They found that there was no added benefit of adding systemic antifungal drugs in patients of fungal keratitis. So this led to a lot of dilemma. The results of these two studies, although they are much talked about, but results in a lot of dilemma. Whether you should start a patient in only one topical drug or you should add systemic drug, because systemic drug, MUT2 says there's no benefit. Now, if there is no response to natamycin, whether we should add voriconazole or not, and when to give intrastromal or intracameral injections, and when to proceed for therapeutic keratoplasty are some of the questions that was dealt in this study, which we published as the TST trial, which was the topical, systemic, and targeted therapy. This was published in Cornea So what we saw in this study was all patients of fungal keratitis that were recruited in the study were started with only topical natamycin. If it was a large ulcer, say more than 5 millimeter and a depth more than 50%, which are known indications for starting systemic antifungal, that is where ketoconazole or voriconazole was started. Patients were observed for 7 to 10 days. If there was poor response to this therapy, it was then that voriconazole was added in a stepwise fashion. Again, the patient was observed for another 7 to 10 days, wherein if there was poor response, then intrastromal or intracameral injection of antifungal drug was added as a targeted therapy. In the course of treatment, if any point of time, if there was a severe corneal thinning or impending perforation, immediate therapeutic keratoplasty was planned for this patient. Intrastromal injections were repeated up to 3 to 4 times at interval of 72 hours if good response was noted with this treatment. So in this study, we had 223 cases that were included, that were cases of diagnosed fungal keratitis based on microbiology, who were not on previously any antifungal treatment from outside. They were started on this TST protocol, and it was observed that the success rate was almost 80%. The medical management group success was 74%. In the intrastromal group, the success reached up to 89%. The requirement for TPK was only in 20%. For corneal perforation, 6.7 and non-healing, 13.5. So as an early use of combination therapy with natamycin and voriconazole and use of intrastromal and intracameral voriconazole, less complications were observed in this study compared to majority of the previous reported literature. So now that we're talking about targeted therapy, what is targeted therapy? So it consists of intrastromal and intracameral injection. The indication being recalcitrant infections, which is treatment given for more than 2 weeks with antifungal therapy, still not responding, is recalcitrant, or a deep ulcer where the ulcer depth is more than 50%. The drug options being voriconazole and ampho-B. And of late, natamycin, the aqueous soluble variant of natamycin has also been tried for the intrastromal injections. This is a short video showing the method of intrastromal injection of antifungal agent. So you use a tuberculin syringe with a 30 gauge needle loaded onto it, and this 50 microgram per 0.1 ml of voriconazole is loaded and injected. So what is important is you inject it away from the ulcer, at least 1 to 2 millimeter away from the ulcer edge or the infiltrate edge, so that you are in the clear cornea. You embed your needle in the cornea so that your complete opening of the needle tip is in the cornea, and then you inject to create a stromal hydration. You make 6 to 8 injections and create a barrage, almost a 360-degree barrage around this ulcer to achieve a depot of injection, which gives a high concentration of the antifungal drug around the ulcer. The injection method is very simple. What is important is to understand the case selection as to where and when to give these injections. Now, these targeted therapy has been evaluated in various studies. The intracameral injections, although have been talked about, but majority of the studies say that there is no added benefit of intracameral antifungal drugs. All the intrastromal injections of voriconazole, ampho-B, and natamycin have also been compared, wherein ampho-B has reported to have higher vascularization rate and slower healing. Hence, voriconazole remains to be a preferred drug for intrastromal injection. However, variable results have been reported in literature. Few studies say that there is no added benefit of intrastromal injection. However, before you proceed for a therapeutic keratoplasty, there is no harm in trying this modality as a last resort. Now, for recalcitrant fungal keratitis, the other treatment options include echinocandid drugs like micafungin and caspofungin that can be tried in patients that are not responding to voriconazole and natamycin. And say if you have a fungal culture sensitivity report which says that the organism is multi-drug resistant to natamycin and voriconazole. Intrastromal, we have already discussed. Nanoparticle is something which is being recently talked about as it increases the penetration of the drug and improves the efficacy of the treatment. So of late, what has been talked about is the topical is the PAC-CXL. So photochrome activated riboflavin assisted corneal cross linking in patients of microbial keratitis it came into discussion from 2013 when it was first introduced. It was initially tried in cases of severe infective keratitis. So this was a study which was published in which 40 patients with severe infection, advanced infective keratitis, were treated with Paxi-XL, and it was observed that although the healing rate when compared to standard treatment was almost the same, however, the complication rate was less in cases with Paxi-XL. That is, the rate of perforation and need for TPK was less in patient where the Paxi-XL was done. Basically, it induces a compaction of the tissue by cross-linking the collagen fibers, which reduces the risk of deeper penetration of the infection, and that is how it basically works. So in this, you basically remove the epithelium and use some riboflavin without any viscosity agent, and the UV beam is directed to the lesion. A both Dresden and accelerated protocol have been described. Fluorescence should be avoided in this procedure because fluorescence, impairs with the UV radiation, the efficacy of the UV radiation that is delivered to the cornea. Repeated use of Paxi-XL has been also been described in cases of fungal keratitis by Hafizi et al. Another advance that recent advance that is being talked about in fungal keratitis is the Rose Bengal assisted photodynamic antimicrobial therapy, which is being propagated by the Bascal Palmer Eye Institute, especially in cases with Fusarium, Aspergillus, and Candida infections, which are not responding to routine therapy. Rose Bengal dye 0.1% is applied to the cornea, and then green light exposure with a total power of 2.7 joule is delivered to the eye, and 2 sittings of Rose Bengal PDAT is applied to the eye. Now, the results of this are very early, and it is difficult to say whether this actually works for these patients or not. Hence, this is all in experimental phase. Something which really works well is povidone, iodine, and corneal scraping. So a simple procedure like corneal scraping, you can see this is the picture. Before scraping, the ulcer looks very large and deep, but you do a scraping, and this is the picture immediately post scraping. It looks like just like a superficial ulcer, and all that was the infiltrate was just like a plaque sitting on the top of the cornea. So corneal debridement and with betadine application and a simple top monotherapy with natomycin in this case worked well. And at 3 weeks, this patient ended up with a healed keratitis and the infiltrates completely resolved. So therapeutic keratoplasty is something that is used as a last resort when if there is a non-resolving corneal ulcer or therapeutic or there is a corneal perforation for which there is no other option but a therapeutic keratoplasty that needs to be done. But obviously, this should be the last resort. And what is important to remember is you should have a good margin because recurrences in fungal keratitis is something very common post TPK. You should always send your host button for cultures when you're doing such surgeries for infections, and post-operatively for giving these patients with antifungal therapy for at least 3 to 4 weeks. Even if you're sure that there is no infection, residual small infiltrates or even fungal balls in the anterior chamber can result in reactivation. Hence, always give at least antifungal therapy for 3 to 4 weeks post TPK in these patients to be on the cautious side. So to conclude, fungal keratitis is challenging to manage. It has variable presentation and different treatment options, but every case is different and management needs to be tailored as per the case that you're dealing with, because no one treatment is going to suit all your patients. Thank you. We can't hear you, ma'am. We can't hear you, ma'am.
Thank you, Dr. Pranita. We have now the last 2 presentations of the evening from our 2 home state speakers, Dr. BP Kashyap, who's right here in the conference hall, followed by Dr. Anuradha Anindya. So you want, Dr. Anuradha, would you like to present first?
Yeah, it's okay. But Dr. Rashid, it's too late. Do you want me to escape? That's fine for me. So, like, I can understand the pain of the.
No, not at all, not at all. Dr. BP Kashyap is kindly, because he does not have to go anywhere, so he's asked you to present first.
Oh, that's great. Thank you, sir. It's always, as usual, you give us the opportunity. Thank you very much, Dr. Rashi and JHOS and Bharti ma'am for giving this opportunity. So today I'm going to present moving ahead in glaucoma management. I'll try to make it as short as possible. So being, glaucoma surgeons, to start with adult glaucoma, one day comes when we think, okay, can we go ahead with pediatric glaucoma or MIGS? So today I'll be focusing on MIGS part. Well, whenever we are starting, we should have the clarity of our target and why we are starting this. We must create a benchmark. Indications, I'm not going into details. It's very well available in the books, and so also the contraindications. Obviously, just to point out, whenever there is elevated episcleral venous pressure, the collective channels are not going to work. So that is why obviously MIGS is not possible. So like when we cannot see, we cannot do. So corneal opacity is that's the cause that why we should avoid. Right. So there are this classification depending on where we are going to treat. So depending on the availability in our scenario, so my discussion will be focusing on like eye stents, KDBs, and GAT, goniotomy, right? So this is the like today only we have discussed about eye stent by our previous speaker, Dr. Prasan. So I'll be moving ahead quickly. We have also discussed, single implant when it was the first generation, and the second generations and third generation coming up with multiple implants and the difference in those cases. Well, this is a point, it's a practical point, so that's why I'll just focus here. I have tried with multiple gonio prisms. You can try anything that you are comfortable with, but if we are trying to start it first, then we should be going with the simplest, easiest, and cost-effective one. So the top one is known as SX gonio prism. So that is like cost is 6,000 to 7,000. I don't have any financial interest. Just to share, it has a claw, so very easily to keep on the eye, and it also allow us for hands free occasionally also. So while doing in the right hand, left hand does not press the cornea too much. Just we have to give one finger behind it to make sure it should not fall. Well, this is just a case recording. Very quickly, I'll be showing the sodium hyaluronate should be given on the iris, on the top of the iris, not in the center as shown. And air bubble is something that should be avoided while placing on the cornea. Air bubble really makes the life difficult, whether it is inside or outside the eye when we are doing gonio, gonio view of the angle. So this is, head tilt is done as per the requirement, and you can see the visualization is very good. But actually, honestly saying, the head tilt is too much. So that's why I cannot see the trocar here. The eye stent, is there, but because I cannot see the trocar, so I have to come out and reduce the head tilt of the patient, so that next time when I am there, so you can see the blood in the Slem's canal. So here I should have targeted the ATM, not the Slem's canal, but I did that on the Slem's canal. So it is actually placed between the PTM and the scleral spur. So the blood gush is not so high. So in my second stent, this time, I followed the instruction and I targeted the ATM only. And I'm doing this target of ATM because when we target ATM, actually we place our implant in the Slem's canal. If we are targeting Slem's canal, then in that case, there is a high chance that we will go posterior. So you can see the second implant and the more amount of blood coming out. That means it is better placed. So the patient is really doing good, and he is off treatment for 2 medications now, and the pressure is maintained very well in 14 and 16. So they're completely out of any medication for last 3 months. Well, so this is one of my case of GAT. Coming to GAT, because it's a treatment of 360 degrees, so definitely the control of pressure is very good. But really speaking, whatever you may explain to the patient, the post-GAT hyphema is really a challenge to explain post-op. and it's definitely a blind procedure, so we really have to be very careful while introducing. So the bank is something that in the initial phase it is most cost effective. Even we can very easily do in our Ayushman cases also. So what I started with, like if the patient has cataract and having glaucoma, so I did bang in every case to see how it is behaving over time when it is closing. And honestly speaking, most of the bank cases actually close after few months, because the margin is really rag. It's not very smooth as like KDB behaves actually better because of the mm, the shape of the blade. It really de-roofs the canal better. However, while de-roofing, a forceps have also used post de-roofing to remove the roof properly so that it should not be again closing. And while going ahead with MIGS, we have to examine our external factors and internal factors depending on what we should do and what we can do. A third party payment system is very crucial to understand because of the cost of the MIGS to be borne by the patient. So that reduces the patient interest to go ahead. But if it is covered by third party, patient is always interested to go ahead with MIGS. So obviously your OT standards, your team, whether they are ready to help you out in all this positional changes, instrument manipulation, everything. Right. So, like any other places, like whenever we apply strategy, so the SMART, goal is used. That's specific, measurable, attainable, realistic, and timely. So the same thing I always prefer to try for any clinical work also. So that's how I started with MIGS. So coming to almost the end, whenever we are going for MIGS, we should be very good in phaco, number one, because the cornea, once it is compromised, I have tried with both prior to phaco and post phaco also. Personally speaking, post phaco is more easier than prior. So, and to differentiate these three conditions, because PSCG, NTG won't be possible to do angle, things. NTG because we cannot achieve our target, and PSCG obviously can't do it. So this difference, to make it, we should be very good in gonioscopy and something to assess the visual field to understand the mechanism which glaucoma we are dealing with. So thank you very much. Ma'am, I think you are on mute, so I am not able to hear you.
Dr. Anindya, actually now the microphone is also giving up. So I thank you for your presentation and must congratulate you. You must be one of the first persons to be doing MIGS here in Jharkhand. And thank you for training and bringing it to us. Now, we would like to proceed with the last presentation of the evening. And very graciously, Dr. Kashyap has been sitting through all evening, listening to everybody and then waiting to present at the very end. So I would say he has been the perfect host for this part 2 midterm JHOS. So, sir, please, we are waiting for you.
Thank you, Rashi. Thank you very much. Thank you, Anindya. Thank you, everybody. Thank you, JHOS. Thank you, Dr. Bharti, to have given me this opportunity to present my very short paper. I'll be talking about the phacoemulsification in very small eyes. Why? Because the eye it could be overall very small eyes, or it could be associated with the microcornea, microophthalmos, etc. So let's talk about both. So what are the difficulties in small eyes? You have a very poor vision since the very beginning. And there is a very poor fixation of the vision, and the patient, it is very difficult to take out the calculation of the IOL power, and then difficulty in having a determination of the axial length and biometry and keratometry. There are a lot of problems in per operative also. And the patient is very apprehensive, because wherever he goes, he's told that we do not know what will the visual outcome. It cannot be predicted. And then you have to know the post-operative follow-ups and the vision, and the patient may come back, patient may not come back. So there are a lot of problems. So, what are the per-operative difficulties? The dilatation of the pupil is very, very poor. Then there can be deep socket. Deep socket itself creates a lot of problem. And they may be difficult akinesis because you know that you may have to deal a lot of things. So I give peribulbar for definite. There is always shallow anterior chamber. You have to be very, very careful if there is shallow anterior chamber, because while doing rexis, it may be difficult because these patients, they come to you late with hypermature cataract, intermittent cataract. So you have to be very, very careful. You may have to put the rexus forceps in and out many times. So if the anterior chamber is very shallow, you have to be very, very careful. And sometimes if it's the microcornea with the microphthalmos, the IOL insertion may be difficult. However, it is said that the lens size is just like a normal person in case of microphthalmos, but there are the difficulties. So it is one of the case, you know, he had both eyes hypermature cataract with PLPR present in both the eyes, and the pupil was non-dilating, and we have in our first prescription we write almost all details so that if anybody sees the first page, he knows what to do. So we have written in capital letters that the patient will require iris soak and the viscoat, and the eye trace was difficult, and the B scan shows very short eye, and the power calculated in the right eye is 49, left eye 43, and if we said okay, we'll go for a plus 40. So there was a posterior synechia, deep socket. We have put the swab there so that there is automatic, drainage. Put the hook. Now look at the rexis. I started the rexis, and the anterior chamber is shallow. So far, so good. Now I want to come out for injection of more viscoelastic. Just look at this moment. Coming out and look. I touched the rexis and I created a iatrogenic Argentine flag sign. So I had to cut open the rexis from both the sides, and then completed the rexis, knowing well that it may extend posteriorly. So now I started with the phacoemulsification, which was not very difficult. So after one chop, I knew it was much easier, and then I could complete the phacoemulsification. And as a last chunk when I'm having it, as a rule, I must take out my Sinskey hook. And very slow. I don't want to take any more chance. And after this, I removed cortical matters and then injected the IOL. While injecting IOL, I have put the lot of visco and started the injection quite before. I mean, the lot of viscoelastic goes inside while injecting the IOL. And I prefer to have single piece IOL instead of 3-piece because I'm not very confident in putting 3-piece IOL because they behave many a times weirdly. And I put the air. The same patient came to me after sometimes 6-7 weeks, and the same finding. I decided to put plus 40 lens, and this time I had no problem in rexis, but then deep socket was there, non-dilating was there, and this is the post-op picture 6/36, and the patient's data was not all that good. In the third case, the IOL power was 38, and she had a high intraocular pressure. It was not coming down by anything, so we had to do vitrectomy and the puncturexis. vitrectomy was done just enough to decrease the intraocular pressure so that I could do all the manipulations of plexus and all that. While doing IA, I saw that there is some amount of dehiscence of the capsule. Probably that was the reason of high intraocular pressure. So I had to put the CTR and then gentle IA. And then single piece IOL. Now, this is a case of macrophthalmus macrocornea. The rexus is not difficult. Now, while cracking, it cracked just like a crack in the wall. And then the phacoemulsification is not all that difficult. I want to show you the trick in such cases for putting the IOL inside. I will inject it. As usual, you would like to rotate the lens inside the bag. So I tried, but it will not go inside. The haptics remain outside. I rotated it, but it was difficult. So in this case, I used my 2 Sinskey hook and pushed the optic of the lens inside, and I used the other Sinskey hook to push the lens from the haptic end. Just have a look. So I'm pushing this haptic end into the bag, and then it goes inside. And the lens is happy, and I'm happy. So these are short things that I want to present to you. Thank you very much.
Wonderful, sir. So nicely shown. A lot of to learn, sir. Thank you very much.
And I'm, as a CSC, I'm very thankful to Dr. BP Kashyap because he always stays till last throughout the 7-8 hours in the first session also. He stayed with us. So thank you very much.
I had to go to a lot of places today. I had to, because the election was there. I had to surrender my arms, and I had to go to Thana, and I was busy since 2 o'clock in the afternoon itself. But then your order was order, so I had to follow the order of the CSC.
And this session, our chairpersons, Dr. Maladi Vedi, Dr. Ratnesh, Dr. Anand Shushrut, Rajmohan sir, they have not joined. Only I can see Pritish Pranoy. This is very bad. After confirming, they don't appear. And I'm thankful.
No, we had a very good attendance, yeah.
I'm thankful to Rashi Shah also. She joined and she has helped in the pot puri session. And thankful to Anindya also. She's very vibrant and always she's there.
Dr. Rashi and Dr. Anindya is very vibrant, actually.
Yes.
Thank you, sir. Thank you very much for all your support.
So now vote out to
Vote of thanks, Dr. Mitra, sir.
So at the as the conference 22nd JHOS midterm conference second part is concluded today just now. This is customary to propose the vote of thanks. I must names the international heroes actually. Dr. Srinivas Joshi, I thank Dr. Srinivas Joshi, Dr. Vishal Agarwal, Dr. Arvind K. Moria, Dr. Devang, Dr. Amar Pujari, Dr. Arati Subheda, Dr. Bharat Gurnani, Dr. Kirandeep Kaur, Dr. Ankita Aishwarya, Dr. Veer Singh, Dr. Prashant, Dr. Subha Prasad. I also thank the discussants, Dr. Ranjit Maniar, Dr. Ruchi Goel, Dr. Vishal Agarwal, Dr. Devesh Kamath, Dr. Pranita Sahai, and also Dr. Vibhuti Kashyap for the vibrant discussions. And that is the part and person of any conference or any talk or any presentations. I must thank Dr. BP Kashyap who just now concluded his talk. He was there in the first session also till the end, and today also he has given the ample time and devoted to this conference. I also thank Dr. B.N. Gupta and Dr. Rajiv Gupta, our past president, because they were present during the conference. Our own in-house speakers, coordinators, chairpersons for their immense contribution for holding this conference. Special thanks goes to Dr. Nandita Agarwal, Madam, our President JHOS, for her valuable time, and none of the is the Dr. CSC, Dr. Bharti Kashyap, who is the instrumental of doing this conference. I must thank Endot for providing us the virtual platform and supporting the innovations, supporting and sponsoring the innovative sessions of Part 1 22nd JHOS Midterm Conference. Thank you all. Hope to see you all at the annual JHOS physical conference at Deoghar, our Baba Dham. Thank you. Thank you very much.